Hello everybody, welcome to our May public board meeting. Good to have you all with us today. Let's get cracking then. We've got a big agenda. Apologies for absence. I think we've got a full house from the board today. Is that right? Laura, I'm correct on that? It is, isn't it?
Yeah.
I'm looking around. Yeah, it looks full house to me.
Karen and Vicky's.
Oh yes, sorry, apologies, just Karen. Karen, apologies, and we've got Vicky with us in her place. Declarations of interest. I've got a couple of changes that I will send to you, Laura, to update. Unfortunately, my husband lost his seat in the May local elections. But there we go. That's politics. That's what happens. But if there's any other corrections or additions, if everybody can update those, that would be great with Laura. Minutes of the meeting held on the 26th of March. I have received this morning a change. I think, Kwame, you got in touch with us to correct the minutes. Apparently on the Associate Hospital Manager appointments and reappointments, the same surname was applied to all the 4 appointed AHM. So it is not a family takeover of the AHM. It is a mistake. And the name should be Jenna Denham for reappoint, Martha Bronze appoint, Leon Elias Bronze should be, Leon Elias, and then it should be Maureen Graham and Alison Cottrell. And I think that's been provided to Laura, hasn't it, Laura, for you to update the minutes. Are there any other corrections to the minutes? No? Is board happy to approve the minutes? Thank you very much. Go on to then the action log, matters arising and work plan. Are there any comments that colleagues want to raise on any of those items? No? Okay, thank you very much indeed. So I am delighted that we can now move to our patient story, and really glad to have our perinatal unit with us, and both a patient who's going to share her story with us, Sophie, as a service user, but also I think we have Sammy and Famanda with us as well. Can I see everybody? Oh, hello.
Morning.
Hello down there.
Hi,
hello on my screen. Hiya. Our perinatal team has been doing some fantastic work, as I'm sure we're aware. I was glad about a year ago to have a chat with some of the workers in that area, and one of the things that has happened is obviously it's moved to a provision on a wider basis than it was originally across Humber North Yorkshire, as I understand. So it's really good to see that its work has been recognised. So it's a really great time to hear from Sophie. We're very privileged to have you with us and share your story, Sophie, and supported by Sammy and Famanda as well. So if we're ready, over to yourselves. Thank you.
Thank you. Hi, I'm Sammy Daniels. I'm one of the CBT therapists in the perinatal team. So the specialist perinatal team is a multidisciplinary service that was originally set up in 2010 in Hull, and it expanded in 2014 to the East Riding, and then 2018 it expanded to North Lincolnshire and North East Lincolnshire, working in partnership with Naviga. And Sophie is a woman from Grimsby. It is a specialist service that offers assessment and treatment to women, their families and their babies from conception through to 12 months postnatal, and it also offers preconception advice with our psychiatrists. The team is made up of consultant psychiatrists, specialist doctors, early years practitioners, specialist social workers, specialist mental health nurses, admin, family therapists. I've probably forgotten somebody, but it's a very big team. We are commissioned to work with 8.6 of the birth rate. We've had recent developments with our front door developing part of the Every Mum Matters campaign, which is where you'll find all the information about our services, and professionals can find the online referrals on there. We have developed a direct referral system, triage and into assessment. Recent developments have been with other specialist pathways, developing a tocophobia pathway, eating disorders pathway, and working in partnership with CAMHS and CMHTs across the services. We have recently developed a Circle of Security parenting group. We offer VIG, which is video interactive guidance, which is an infant mental health intervention, family therapy clinics, and we offer seminar series, which is your kind of online training across the trust and inviting other services in to be part of that. My role in the service is as a CBT therapist and EMDR therapist. So I met Sophie in November 2023. She was referred into the service in September 23 after having her son at the end of August. She was assessed and seen by Charlotte Morton and Dr. Harding from the Navigator side and taken onto caseload and referred for psychological therapy with myself. So here is Sophie's story.
Hi, everyone. I had always wanted to be a mum for as long as I can remember. I turned 30 when I decided the time was right to start trying for a baby, so I felt as prepared as you can for a little one. I was so incredibly lucky and fell pregnant within 4 months of trying. During my 8-week appointment with a midwife, she informed me that my pregnancy would be classed as high risk due to cervical cells being removed when I was 25. This would mean that I would be on a consultant-led pregnancy path, which I now realise is very common, but at the time I had no idea and therefore began to feel quite anxious. I had to have my cervix checked every 4 weeks to ensure my cervix was strong enough to carry my baby to term. Finally, the 24-week mark came around and the pressure eased a little as the additional cervical checks were no longer required. When I was 16 weeks pregnant, my dad had a knee replacement surgery, which unfortunately led to sepsis and an induced coma. I travelled hours every night after I finished work to see him in intensive care until he finally passed away 8 weeks later. The experience was very distressing and drawn out for numerous reasons. I got into the 3rd trimester and began with severe pelvic girdle pain, massive water retention and fluctuating blood pressure. So it's safe to say I didn't feel I was able to enjoy any part of my pregnancy. From 38 weeks onwards, I had every cervical sweep available to try and get labour to start, just to stop the constant pain I was in. On my baby's due date, I felt a strange movement, so I went into the hospital to be checked. They informed me that the movement was the baby rotating round into the back-to-back position and that I was starting contractions. No other information was given to me at that time. I found out later that this position is nearly impossible to birth naturally. 30 hours later of constant back-only contractions, I found the pain unbearable and went into hospital. I began throwing up with diarrhea constantly. I shut down, stopped communicating, nothing was helping, and I was worrying for my safety as I knew this couldn't be normal and the doctors and midwives were very concerned. After trying to get my baby's heartbeat and failing, the decision was made to perform an episiotomy and use a suction cup to get my baby out safely. 36 painful hours later, my son was here. During the chaos of labour, I agreed to a single shot of Pethidine to try and help. I was given leaflets regarding pain relief at an appointment 20 weeks prior to this. Safe to say, I didn't know or was informed at the time of that shot that my baby would go onto extra monitoring. On one of the extra checks of my baby, when he was around 4 hours old, he turned blue and his heartbeat couldn't be detected. The midwife pulled the emergency alarm and lots of people came in the room to check on him whilst me and my husband were ushered to the back of the room, confused and scared beyond belief. After the longest 10 minutes ever, they informed us that he was okay, but as a precaution, they were going to move him to the neonatal intensive care unit. I spent as long as I could with him there that day, but I was told I needed to go and sleep some, so I reluctantly went back down to my room on the ward. I managed 3 hours rest before I went back up to him. That day, family came to visit, and on one visit, I realised I had only slept those 3 hours in 4 days with quite an intensive labour in there. I tried to sleep and just couldn't switch off. I thought it would be better when we were discharged to home. Sadly, I was wrong. Just before being discharged from the hospital, we had been informed my baby had been infected with MRSA during our stay. We were given absolutely no other information on this other than a midwife will come to our home and explain how we wash the infection off our baby daily with chemicals until he was clear. When we got home, I was in such a heightened, almost delirious state, I just could not sleep. Every time I fell asleep, my body would jolt itself awake within minutes in a panic state. I called the midwives, the hospital ward, my GP, anyone I thought would listen, to be brushed off with the baby blues. Luckily, I had a fantastic midwife come to see us on day 3 of being home, who put her foot down with the hospital to have me seen, explaining I was on the verge of being psychotic. I was given an injection to help me stay asleep. I got back home and had 2 hours of broken sleep with the constant jolting every time I fell asleep. Hysterical, I went back to the hospital and begged to be sedated. I felt as if I was losing my mind. I wasn't sure what was real or what was illusions. I was given strong sedating medication to sleep. Again, I only slept for 2 broken hours with the jolting in between. The next night, I was given stronger sedating medication. I slept for 5 solid hours and decided to go home with the same medication. In my mind, 5 hours was better than the broken 2 or none I'd been having. During this stay, the crisis team or the hospital psychologist, I can't remember which one, had referred me to the perinatal mental health team. The 5 hours sleep I had in the hospital was a one-time event. I slept for 2 broken hours again on the same medication with the jolting continuing, and I began contemplating taking my life. I was told the medication I had taken should knock anyone out for a good period of time. Unfortunately, along the way of my pregnancy, birth and aftermath journey, I was misinformed, misled and lied to on numerous occasions by different health officials. At this point, I felt completely hopeless that anything or anyone would ever be able to help me. I felt so isolated and broken and began trolling the internet, trying to find anyone or anything that shared the same experience as me. There was nothing. I really felt like I couldn't carry on, that I was getting in the way of my son and my family's life. On my first day back at home this time, the perinatal mental health team rang me. I remember thinking, wow, that was so fast, but also no one can help me, no one cares. An appointment was made for someone to attend my home the day after to discuss everything that was happening. Charlotte, a nurse from the team, came to my home, discussed my pregnancy and aftermath, and went away to consult with one of the team's doctors. Within a few hours, the doctor was also at my house with Charlotte. They prescribed me with stronger medication for a longer period of time and explained to me that I may be suffering with PTSD and postnatal anxiety. Before all of this, I had never taken any medication at all. I was so scared about what was happening to me. Charlotte began checking on me daily, as well as getting me regular checkups with the doctor to discuss my medication, and referred me to one of their therapists. The insomnia/jolting awake continued for 8 weeks, even on sedating medication. It felt like I was being tortured every day. During this time, I also began to unhealthily obsess about my baby's safety. If I wasn't planning on how I could end my life, I was analysing every single thing my baby was doing that could end his. I felt like I wasn't fit to be a mother, that I wasn't fit to look after my baby in the condition I was in. I was also spending this time preparing my family in readiness for me not being here anymore, as I knew that would be the only outcome for me. I just had no hope it would ever get any better. This is where things began to turn around for me because of the perinatal mental health team. I had zero hope that anything the NHS could provide me would actually help due to the unfortunate letdowns I had experienced for over a year. I'm not ashamed to say I was completely wrong. Charlotte's continuous supports, check-ins, visits, conversations really did save my life. I would not be here today if I hadn't have met her. I have never felt such genuine care from a healthcare professional. I couldn't believe it was happening. She got to know me, how I was thinking, how I thought before, who I am, what makes or made me happy, what I was doing daily, just everything about me. She spent hours talking to me, reassuring me, comforting me, counselling me, as well as my husband. She was absolutely incredible. Her kindness and personable attitude towards her work shone through in every single minute I spent with her. I can't think of a service in my life where a person like Charlotte exists. The service she provided me with was literally life-saving. Emma, an early years nurse practitioner, also began to visit me to try help with my connection with me and my son. She spent so much time trying to show me that despite the condition I was in mentally, that I was able to be my son's mum. She then went to another level and spent months showing me that my son did in fact love me back when I was adamant he didn't, blaming myself for those 8 weeks where I was a complete shell of a person. I think to this day, I will still believe that my son didn't love me as his mother, something which I can see now wholeheartedly, all down to Emma. To give this gift to a first-time mum who believed there was no purpose of their existence in this world is the most incredible gift I will ever receive. Before this experience, I'd never undertaken any kind of therapy. Sammy became my therapist rather quickly after referral. In my desperation, initially I was really frustrated and impatient to be better, or to feel something other than the horrific feelings I felt all day, every day. Unfortunately, I let this frustration out slightly in my initial appointments with Sammy. I didn't understand that it would take some time. Sammy spent the first bulk of our sessions understanding me, listening to my frustrations, and coming up with a clear plan moving forward with my whole journey in mind. Every step of the way, she explained to me what we can do at each part of the journey, when I was ready for it, what it will look like, as well as checking in on my general well-being every week and making sure I was happy with what we were doing. I spent a year working with Sammy with weekly sessions. She became one of the most important people in my life. Eventually, I looked forward to our sessions. After each one I had relief, I felt like I was able to live again. Slowly but surely, using the technique she is incredible at, I began feeling better, even experiencing some happiness again. The work Sammy did with me unintentionally unpicked so much of my life, not just my pregnancy and aftermath journey. She made the hard work we were doing feel easy. She was so professional and experienced. I felt so safe with her. She made me feel like I matter, that I deserve happiness, that I deserve more than I've ever allowed myself to feel before. I said at the start of our journey, I had 2 goals. One was to believe that my son had a future. The other was to not let the sleep and insomnia ruin my life forever. She succeeded in getting me to achieve both of those goals. She really understood who I was before I got pregnant, who I was afterwards, and who I am now, and amended and adapted a treatment plan with all of this in mind to tailor therapy to me specifically. I've not heard of another therapist yet that has successfully managed a patient this way. Sounds strange to say, but I will really miss our time together. The impact she and the therapy undertook with me will stay with me and my family for the rest of our lives. Every doctor I encountered was so incredible also. They really took the time to understand what was happening to me and did everything they could, including regular medication reviews with my desires in mind. They were all so informative and supportive at an incredibly scary time. I wish I trusted them sooner than I did. They were all fantastic. They really restored my faith and hope in GPs and other doctors. I cannot say it enough, but I'm enormously and forever grateful to the perinatal mental health team. My son has a mother because of them. My husband has a wife. I have my life, all because of this incredibly invaluable team. Thank you.
Thank you so much, Sophie. Can I just say, as a mum myself, but also as an NHS chair of this trust, I just want to say also I'm really sorry that was your experience as a first-time mum in terms of your antenatal and postnatal care. I think what you've described is something that is not acceptable, and where women are just not listened to when they both are most vulnerable. And I just appreciate you sharing with us that, because I think that's what you've said is really important about, when women are the most vulnerable, when they are pregnant, they are listened to. And, obviously it impacts you, but also your husband and family as well. But I'm so proud and delighted that our perinatal team were able to give you the support and your journey to recovery. And I thank you so much for your praise for them. Praise enough is seeing you today and hearing how your journey and how your strength has just shined through today in terms of what you've been through, and a happy family life ahead. for many years. So thank you so much for that. I don't know, Sammy, or would you like to just say anything else before we open it up? I've got hands up at the moment. Sammy, was there anything you wanted to add before we went to questions and comments?
Just thank you for Sophie being so brave to share a story. It's an absolute privilege to work with women like Sophie, and our time together, I looked forward to the sessions. She was just amazing and has come so far, and it's a really proud time to listen to the story.
Thank you. Okay, Priyanka, and then I've got Michelle, and then I've got Lynn, hands up. Priyanka.
Thank you very much for sharing your story. And when I read it, I was thinking, as a mother of 4 children, what difficulties, even with a lot of social support, family support, how you can become, especially even if your children were healthy, what lot of stress that you go through at childbirth. And I was glad to see that you were going to share your story in the Navigo magazine, was it? So that would allow a lot of other people to, seek for support that's out there. And I was wondering if the Trust could maybe share in the Trust social media as well, with your permission maybe, and that would be a good thing. I don't know who will look after that side of things. And my question is from to Sammy, really. If a mother wants to refer themselves, do we have like the opportunity? Do they have to be in some sort of to be referred to the perinatal team? Is there a waiting list, or can anybody if they are in need, get in touch with yourselves?
Directly to the perinatal team, yes, professionals can refer directly to us, and that's when our kind of referral support system will enter at the front door, offer a triage and an initial assessment, and then they can be offered all of those interventions if they meet our threshold for moderate to severe or complex mental health needs. And if we believe that they do not meet our threshold or criteria, then we would always do our very best to signpost or refer on to more appropriate services. So there isn't an initial waiting list. There may be a wait for psychological therapy interventions. That's through myself, CBT or EMDR. However, Sophie was seen relatively quickly, which was great. And I think that allowed us to develop that relationship that was needed initially to help Sophie believe and trust in the process, I think.
Thank you very much.
Thanks, Sammy. Michelle.
Yeah, good morning, Sophie. Thank you. Michelle Mack, Chief Exec. I'm a midwife by background, so obviously it's really interesting to listen to the story, and thanks, Sammy, for all your work and the team's work. I just wondered, can you mind if I ask, what's your son's name?
Of course, yeah, it's Kurt, Kurt.
Well, I presume Kurt's fine now and driving you, yeah, that's good.
Yeah, he's a great handful.
Excellent, that's what there should be, but a positive handful, that's great. Just a couple of things for me. I was a bit, obviously, I appreciate our team, the work that they do, but just hearing it firsthand is really important. And, when we get into these states, conversations about service delivery and models of care, it's really good to have that service user experience and feedback, so it doesn't go unwanted. So thank you for that, because we can feed that into the system to support the development of the team and continuation of the teams as well. So thank you. I was just a bit anxious about, maybe we need to probably take it a bit offline. I don't know how much from the hospital point of view about what the poor experience that you'd had. And I don't want to get into the conversation here, because I don't think that's right for us to do that, because it's not what we're here for. But I just think, has that been picked up? Have we fed back those experiences into the hospital? Because we want examples and commentary around the services we provide. I'm sure they might find that quite informative if you feel like you could share. So maybe I can leave that with you and Sammy to think about, and if I can, maybe or one of the team can help with that, or maybe Sarah or somebody. I think that would be helpful if that's possible.
Of course.
But I just wondered if there's anything else you think we could do from an organisation and from a team point of view. Obviously, the access was quick, which is good. Is there anything that you feel that would improve it further? It's obviously fantastic, which is great. But anything for us as a board that you'd want us to take away with in relationship to the service?
Not for the perinatal mental health team. Honestly, the service was perfection. There's nothing I could actually pick out of there. There's a lot I could pick out of in the journey, which, like you said, is obviously not the time to discuss, but I'm more than happy to give Sammy some detail to pass on with that, or Fee. I'm more than happy to do that, because I think there's a lot of changes that could be made in that respect. But yeah, not to the perinatal mental health team. That they honestly were perfect.
Thank you, and thanks for that. That'd be really helpful. And thanks, Sammy, and the team as well. So a great way to start with board. Really powerful, really powerful. And that's what we need, because we can keep that in our minds when we talk about the business that we've got in front of us. So thank you so much. And I know it's really difficult, to, especially virtually as well, to speak to a load of people just on screen. But you presented it so well. So thank you for that. And all the best wishes for you and Kirk and the family.
Thank you so much.
Thank you, Michelle. Lynn, and then I've got Kwame and Sarah.
Thank you. Sophie, I'm Lynn Parkinson. I'm the Chief Operating Officer with the Trust. But thank you so much for sharing those experiences, both the very negative ones, that experience that you had of the emotional distress that you experienced. You articulated that so brilliantly well. And as an example, Sammy, of the support that you provided and how that was so positively received by you, Sophie. I mean, that's an amazing story. Thank you so much. I was going to ask you specifically, because I happen to chair the perinatal partnership board that we have in the Trust that brings the other providers together. But we're always a bit focused on sort of post-vention after people have started to experience. But it is that prevention piece as well. I don't know if you've had any thoughts about that. But in your view, given your experience, is there more that we can do you think, to support mothers before birth that may well experience, whatever sort of emotional distress following birth? Would that have made a difference, do you think?
I think so, because I think, well, first of all, if I would have been referred to the perinatal mental health team when my dad passed away, that would have been a big help. And then also, I don't think the midwives were equipped to deal with the issues I was having with the insomnia and the jolting and things like that. And it obviously got very complicated because we'd been given MRSA in the hospital also. I think that midwives and health visitors could do with maybe picking things up a little earlier. I would have liked to have been referred to the team earlier, specifically when my dad passed away. And I think, I saw consultants all the way until the end of my pregnancy and extra monitoring. Nobody offered me that service. I didn't know it existed until it was kind of too late and my body was stuck in that fight or flight mode. But like I say, I don't particularly blame anyone. They were doing their job, but I do think the midwives and the health visitors could have maybe spent a little bit more time trying to get me prevention help prior to birth.
That's really helpful. I think that's something that we need to take away, Sophie, and I'm more than happy to pick that up through the board, as I said, because we do have some responsibilities around training, raising knowledge, awareness. So thank you for that insight. That's helpful.
No problem.
And I'd just like to, I was just going to add, I think it is important to say that the piece of work that myself and Sophie did do was tracking back in time right through to the beginning of the pregnancy, and all of those kind of traumas that occurred during that we worked with. It wasn't just the postnatal trauma that Sophie experienced, and that's where the prevention would be.
Yeah,
obviously.
Thanks, Sammy.
So that gives you a good sort of narrative, doesn't it, Sammy, around the different, I suppose on one level, the different points at which some more intervention or signposting could have been helpful as a case study in its own right. So that's really helpful. That's a really helpful piece of information and work there, I think. Okay, Kwame.
Yeah, thank you, Sophie and Sammy, for sharing this insightful into the perinatal services, and Sophie for your journey of recovery to share with us. I think the ask from the board, which you've shared with us, was for the board to support perinatal services and to support investment. As you know, as NHS go into difficult financial process, sometimes the energy from mental health is to support perinatal service and all our services. So as a chair, I suspect that the board would want to assure you that we would continue to support perinatal services because it delivers care for not only mothers, but for babies and families as well. So thank you.
Thank you. If I would be able to just add to that, sorry.
Yeah, go on, Sophie.
I was just really mindful of the sort of time limit that I had. Sammy had to sort of keep working with me on that because it very quickly came up to Kurt's first birthday, and I didn't feel anywhere near ready to lose the team. Obviously, the transition back into life, my working life, I barely enjoyed any of my maternity leave with him, that kind of thing. And I was really mindful that I would be losing that service when he was 12 months old. Luckily, the team did keep me on because I had another episode where they kept me on a little bit longer just due to duty of care. But I don't know if the board would ever consider keeping mums until the babies are 2 just to help transition back into life. I'm not sure if that's something possible. It's just a suggestion from someone who's used the service, especially if someone's waiting a little bit longer for therapy intervention. I was really lucky because my case was severe, but if somebody's waiting months and it's eating into that time where the baby's getting older, that was just a suggestion.
No, thank you for that. I think that was raised by members of the perinatal team when I met with them for a chat about their work. I don't know if any of our EMT, Sarah, you've got your hand up there. Could you maybe deal with that and raise your point as well, or take it away?
So thank you, Sophie. That was such a powerful story. So thank you so much for being so really brave and sharing that with us this morning. Thank you so much. Mine was kind of linking in with what Michelle said. So I'm Sarah. I'm the Director of Nursing here at the Trust, and I'm really keen to sort of explore with Lynn how we can maybe explore some of those sort of missed opportunities, and that's kind of how I'd sort of describe them. So there was clearly some really traumatic experiences from the outset of your sort of journey, and I also know that maybe you're not there yet in your journey, but there's also something around that. I'm really keen that if you ever feel that you want to have further children, that we can support you in that next that next place as well. So it's really important that we think about what that looks like moving forward for you and how we'd need to support you as collective NHS services sort of moving forward as well. So I think, we've still got part of your journey and we need to sort of think about that. I think the comment around the pathway and that, I know Lynn's just put in the chat that actually we've got the new maternal mental health service, which is going to be working alongside the perinatal health service, and that's commencing next week, June, this week, I've lost track of days. So that's imminently sort of starting as well. So that'll really complement that piece, sort of, Caroline. So there isn't that kind of end of pathway. It'll be very much around those two services working collaboratively together. But happy, Sammy, if you want to sort of connect as well, if we want to do some learning with the Acute Trust, I'm happy to support that as well. So I'm happy to pick that up offline. But thank you again, Sophie. Thank you very much.
Thank you, Sarah. Really just thank you to Sophie very much. And just to maybe sort of just summarise, I think one of the things which Priyanka said was about looking to share on our social media platforms Sophie's story that's going to be in the Navigo magazine. I think, we work with Navigo They're part of our partner organisation, collaborative work we do. So if we can do that, I think the other thing that's come across really strongly here as well is the prevention side of things. You know, it doesn't mean sometimes, you know, clearly, you know, expectant mothers might have an easier birth journey than you experience, but they still might post-birth need the services of our perinatal, sorry, get my wording right there, our perinatal mental health team as well. However, it does make me think about, and when we look at our agendas and our reports on recovery and prevention, this is a really good example where maybe some more discussion offline about what could have been done to think about preventing some of this is part of that, and exploring that within our own strategic objectives in services like perinatal as well as others. And I think the other thing about the time limits thing is quite interesting as well. So thanks to EMT who might take that away and think about that and how it might fit in with the new maternal mental health launch alongside our perinatal services as well. So I think that's you've given us a lot of things to think about for the future, as well as great to hear such assurances around our own service in this area. So thank you, Sophie. Thank you, Sammy, and Amanda, who is off screen, I think, might poke her head in again. Hello,
Hi.
There's a hand. Nice to see you. And our best wishes to everyone in the team. Thank you so much. Thank you for your time today.
Thank you. Bye.
Thanks, everybody.
Thank you.
Bye-bye.
Great.
Well done. Thank you.
Okay, thank you very much. That was a really, really helpful, I felt, story today, but also more work to be done, I suppose, with us and our partnerships with others. Okay, so moving on to my report, I just want to mention a couple of things just to say I'm really pleased, and it's in, I think, your chief exec's report somewhere, Michelle. I'm really pleased to be part of some consultant interviews, 3 of which have popped up, I think, in this chief exec's report somewhere, who've been approved and what have you. It's really great to have these interviews and for them to be successful. So that's good to see. Can I just give a shout out as well for the Culture of Care showcase that some of us all attended in the last fortnight. There's some really great work being done, both with staff and with our patients and service users, to think about some of the things that and sometimes quite small things that can make a massive difference to people's quality of care. And I know it started in 4 of our wards, including Town and Court, which I visited just before the event. And the plan is to expand it further, the learning from this. But it really just demonstrated something that is, I felt, really practical, impactful, and actually in some cases, you know, we should be doing it anyway. And just to say, Nikki Grattan, some of you may remember, she actually came along to the board not so long ago to present. She presented the other week, and Amber Waddington as well, 2 of our service users who are working on co-production. They've done tremendous work, I think, on this as well. So I just wanted to give a shout out. Congrats as well. It is formally been announced that Inspire got a good rating for after their CQC inspection. And hot off the press, the results came in yesterday for the staff governor elections for our governor's body. And our new clinical staff governor is Sian Johnson, who replaces Will Taylor. And Simon Mills is our new non-clinical governor. So congratulations to Sian and Simon. But could I just take the opportunity to thank Will Taylor for all his service and work during his term of office as a staff governor, and also for the work, obviously, he does for us in the trust as well. Any questions on my report? No hands up. Okay, thank you. That is noted, and we move on to Michelle's report. Michelle.
Good morning, thanks, Chair. I'm not going to go through it in too much detail given the size of the agenda. Hopefully people have had a chance to read it. I will pick out just a couple of pertinent points, but leave my director colleagues to put if anything they wish to do. There are a few policies there, as always. Well, there's 2 to agree, and as the Chair's mentioned, we've got the consultant ratification appointment. Lots of things around visibility across all the directors' reports. It's great to see such a wealth of visibility across in various different areas as well. So I think that's really, really positive. I was really pleased to be contacted and then actually see it in print, the NHS providers annual report, where we're actually mentioned our services are a key feature from a children and people. The link is in the report, and I would like to thank the team, particularly Justine and others, for contributing to that, but obviously for doing the services that actually warranted getting into the NHS providers annual report. So thank you for that. Every year the exec team talk about the objectives, our strategic goals, alongside the board conversations that we have at strategic board, and pick out a few key priorities. That doesn't mean we're not doing other things, but just things to really give a little bit more attention to. And they're contained on page 4 of the report. And I think most of you will recognise them from things that we've talked about at the strategic board, and we'll continue to press those through the exec team, through the operational delivery group, through the various structures, but more importantly through the board committees and with our non-exec colleagues. Couple of things around the patch that I've obviously put the mayoral election results in. It's fairly early days yet, but we're working through the implications of those, and I think we're trying to set up meetings with them about just general things, and that health is not necessarily a key out of their manifesto and portfolio holder, but it's important. Jason Stamp has been appointed acting chair of the ICB until September, is my understanding at the moment. And as you know, Jason is very strong within the voluntary sector in Hull, and actually led that collaborative, but also worked on the HR project, the breakthrough project in the human resources piece. Hot off the press, Simon Morritt, chief executive from Scarborough, is retiring in September. That came out after the report came out. It came out on Friday. So more movement within the city. And also Lisa Revel, which is in the report as Care Plus Group acting chair, has now been confirmed as interim chief executive until December. So there's a couple of extra bits that didn't actually quite make it because it was literally hot off the press. There's a little bit in there from Lynn's point of view about the ED streaming, which I draw people's attention to. It's really important. And you'll also notice in the performance report that we are now having to report our metrics on ED weights. And I think the work that Lynn and the team have done on the ED streaming is really great and really contributing to patient care and outcomes, but also reducing waiting times in ED in the emergency department. We've got, obviously, the chair's mentioned the CQC report, the developing statutory mandatory training, memorandum of understanding. There's a bit of a report on there, an update on our Respect campaign, which I think is really important. And we'll go on to the where's and the des, as we always do at some point. A little bit more about digital, and we're going to concentrate on digital with the board through the strategic board meetings as well. And then there's a usual communication report and health stars report. There's lots in there. I'll just have a quick look around my director colleagues and see if there's anything you want to highlight. If not, Chair, I'll pass it down for questions. Are you on mute, Caroline?
Thank you for that, Michelle. Any of the executive director leads want to add into this report before I bring in Stuart and Steph and Phil? No? Okay, let's go on to Stuart.
Thanks very much. Morning, everyone. Thank you very much, Michelle and colleagues, for a very detailed report, as usual. I've got 2 questions, which are both about effectiveness. One in relation to the ED streaming. So we've got some charts about kind of throughput and response times and number of people seen. Are we also understanding whether the streaming service is as effective, differently effective to an in-person service? Question number 1, and I'll just hold the second question on a different area. I don't know who wants to pick that up.
Lynn, do you want to pick that up? I mean, ED streaming is actually based around the emergency department. It's not virtual. They come in through the emergency department and are immediately go into our AD department there. Right. But I'll let them get that up. So it might be just the terminology, Stuart, but
it definitely is a terminology. I assumed it was a virtual intervention.
No.
Okay, I've learned a lot then. Thank you. And
let's maybe think about the terminology.
Yeah.
You're right to point that out, Stuart.
Yeah, that's a good point. It's a good point. Use of language. Lynn, do you want to try anything?
dreaming is a national terminology associated particularly with ED departments, but I absolutely agree with you. It's not very individual centred, is it? Hence why we just call the suite, which is a physical suite, Stuart, adjoined to the emergency department, Hull Royal Infirmary.
Yeah.
So service users with a mental health presentation are triaged as normal, walk through the doors of ED, but are picked up by our liaison team very quickly, within a maximum of an hour typically. And then if they meet our criteria, which is actually quite a broad criteria, can have their assessment and then ongoing planning for their treatment within that facility, which is purposely designed, and actually the feedback that we get, I didn't include it this time, but we do collect patient stories very frequently around people's experience and carers as well, because that ED experience, when you're experiencing, any crisis, a physical or a mental health crisis, but on this occasion a mental health crisis, that can actually be one of the most, difficult times of people's lives, can't it? So how that experience is for them, can actually determine. We've just had a story, haven't we, about, first-hand experience of, physical health interventions and when that doesn't go well. So our feedback from our service users is really positive around this service. And obviously it's not, I wrote this, more than a week ago to put in this report, but obviously it's been nationally very topical over the last few days as well, with the talk of the, alternative crisis centres for mental health presentations.
So leaving aside my own ignorance about what the service really is, thank you for clarifying. I've learned something. I think you answered your question is you are measuring effectiveness of the service as well as what I might call throughput stats.
Yes.
Thank you.
Yes. But one of our key measures is that those service users and their families that otherwise would be in the main ED department, the number of hours that now doesn't happen for, but also the experience and the outcomes for those people being much improved.
And we've actually fed that into the national team as well, Stuart, because we're very surprised that we're actually the only mental health trust that actually does the ED unit in, as it is now. So I'm sure expecting that to roll out. But and also the suite was designed by service users themselves as well, which I think is really important.
Interesting. Yeah. Thank you. Chair, can I have my second question?
Yes, you can.
So it's on similarly effectiveness. I just find me a note. And it's to do with staff, looking after staff and their wellbeing offer. And we've got data in the report about staff taking up the offer on MOTs and other activities to reduce their absence and so forth. Are we actually tracking the effectiveness of that programme in terms of sickness, absence, retention, job satisfaction, and all those metrics in a way that we can link, if you like, cause and effect?
I think that the clear answer, I'll bring Vicky here, but I think the clear answer was to start off with probably not as much as we probably should have done, to be honest, do it in that way, but we're getting better at tracking that now and developing those metrics. So we still need some work to do, to be fair, but we are on with it. But the MOT, it has gone down exceptionally well, and we have actually we've actually picked up and referred on people who have subsequently been being diagnosed with long-term conditions, but are manageable because we've picked them up. So it's really detailed. Check. And I know it's gone down exceptionally well with staff. And again, we're one of the few organisations that does that. But Vicky, I don't know if you want to just pick up a bit more about the metrics, but it's still work in progress. We've got some detail, but we need to do a bit more of that.
Can I just, before Vicky comes in, just because Stuart's picked up something, I was looking at it because I see that massage and yoga are the most popular of the MOT outcomes. And when I look across at the sickness rates in some of our units where it's mental health and stress, what I'm not clear about is who are the people taking up these opportunities and whether there's a correlation between the people who are off sick most through stress and anxiety. Are they actually, in terms of prevention, getting these sort of services? That I'm not clear about it, Michelle. And I'm not clear from the table whether it's some of the same staff going to several of these activities, or whether the total sum of 600 odd are 600 individual staff, rather than sort of double counting, if you like, across these services. So I think it's a good point that Stuart makes.
And as I say, it's work in progress, Chair. And I think we do double count a bit of that. But again, we can argue that, yes, because obviously we've done a lot of work on sickness and we still need to do a lot more because our figures aren't particularly great across some of the areas. And as you know, it's a real theme of the exec team that we are constantly working through. And it's about understanding that data. You're absolutely right. And we are getting better at it, but we still need to do more and correlate it with the offering that we've got and who has taken it. Because it's invariably sometimes the people that don't go off, which is great because if we're preventing that, that's fantastic. But could we have prevented it more? And that's the conversations that we're getting into. But Vicky, do you want to add anything at this point?
I think I would echo what you said, Michelle, but also that we do an annual insight report into the wellbeing offer, but we can look to incorporate some of that data into there to review it and see what it's telling us. But it is work in progress. It is something we're aware of. And just on the offers of massage, sometimes it could be double counted, but it is something, again, we can look at.
I think it's about, being clear about what the data's telling us and what the outcomes are and how it connects joining the dots with other strategies to reduce sickness and absence.
Indeed. Yeah.
And if you don't know who the people are who are doing it and you see that against the people who are going off for days sick here and there because of mental health and whatever, we're not going to know. Okay. I've got Steph next.
Thanks, Chair. I just want to go back to the Humber Suite at Hull Royal again, which is a fantastic service and really successful by any measure. The government's really recently announced a move to have what they're terming mental health A&Es across the country. And I just wondered how that would impact, do we know at this stage, on Humber? And whether that would extend to further supporting the sustainability of the Humber Suite, or whether we're going to need to change our approach.
I think it's a really interesting question, Steph. And I think as we come on to the finance piece, there's not going to be any further additional investment. So it's about using the resources that we've got in slightly different ways because it is so effective. Then we would obviously regenerate and move that around. But to actually say there's going to be more money come through for it, I think it's probably unwise at this stage to gather that. It is sustainable because we've done it within our existing resources and a little bit extra money that we got. So our unit is sustainable because it is about remodelling that. And it comes back to that productivity, I hate that word, but that utilisation of efficiency, looking at the system, looking at what the data's telling us. And what Lynn and the team did was restructure that. And if we had something at the near point of admission, because people are going to go into the emergency department, what we do, we're not going to stop that happening. So because obviously we've got crisis hubs around, and some of those were more successful than others. So what we did is regenerate some of that money and put them where they weren't successful because they weren't being utilised into the front end of the ED. Once we got a successful capital piece from the acute, which took a bit too long, to be honest, to get us the right space in the emergency department. But we wanted it there on purpose. I think to answer your question, how is this sustainable? I think, yes, there is that bit to expand it across other areas, and I think they'll have to look at doing things in a slightly different way because I can't see there being pots of money towards that. If there is, then obviously we would want to get that to continue hours and to extend it a little bit more and maybe to put some more clinicians in there. But at the moment, I don't think it's about using what we've got in a slightly different way. I don't know if you want to add anything, Lynn, or if that's fine.
No, which is why we do think our model, it isn't right for every place. Our demand through that Hull Royal ED for mental health presentations was exceptionally high. So therefore, recrafting our mental health liaison team, as Michelle says, we've achieved this with very little additional resource. It's actually an adjunct to the already pre-existing hospital liaison team that was there. But actually, that's why we do think it is a model that needs consideration nationally because it has been achieved in that way. I think there's further work that we're still focusing on actually what would prevent folk attending ED departments anyway with mental health presentations, but that's the work that's what we're doing alongside our other partners and agencies around sort of community and neighbourhood models as well. But as a direct alternative to ED and easing the ED pressures, I think this model really demonstrates how effective it has been at achieving that. So I do think we will continue to raise it nationally when we demonstrate its impact to people, nationally. It's, I do think it's a model that needs some national, consideration, which it is getting and has done since we implemented it. But for this type of population, this is an effective, cost-effective, productive model of delivery.
Okay, thank you very much, Lynn. Phil?
Morning, everyone. One quick comment and a question. The comment was about Humber Suite. I noted that the Humber Suite's got 3 times the throughput of Claire Murdoch's Mental Health A&E, and that covers a third of London. So there's we probably need to understand what's being proposed nationally and what our Humber Suite provides versus that, and because obviously I was well embedded and busy.
I think Claire Murdoch's actually probably was devised out of ours, to be honest, Phil, if I'm absolutely honest. I think it came after the one that was in the Times this week. And yes, I think it's just still developing. It's still in its early phases. If we leave it there, I think that might be helpful.
Lynn, are you briefing the governors about this tomorrow?
Yes.
Yes, we have. Yes. Absolutely. Myself and Adrian elsewhere.
We need to learn a little bit more about this. The question, it sort of relates also to the performance papers, which is the increase in waiting times of children ADHD and ASD. And I just feel that I need to highlight increasing concern about how we look after those patients on the waiting list. And if we could just sort of highlight what we do to risk assess. I know we've talked about it in Quality Committee and here before, but I just think looking at the increase in over 52-week waits, that we just need extra assurance that that we risk assessing people sat on waiting lists.
Do you want me to pick that up, Caroline?
Yes, please, Lynn.
Yeah, so for obviously the over 52-week wait for those children presenting with ADHD and ASD are still going in the wrong direction at the moment. But as I've described here before, we do have strong standard operating procedures in place in terms of contacting people on the waiting list on a very regular basis. So our expectation is there is a point of contact of one type or another on a weekly basis, and obviously clear messages to those people waiting that should their needs increase, that they have direct access to assessment at the point that that's required as well. And we do audit that those protocols are being applied and followed correctly as well. I will pick it up again, if that's okay, Phil, under the performance report about further work that is taking place across the ICB around these waiting times specifically.
Thank you. That's very helpful, Lynn. Thank you.
Thanks very much, Lynn. Priyanka. Priyanka?
Hello, sorry. My question also relates to the same issue. I looked at Michelle's report, and then she has said there, unfortunately, some children on about the neurodiversity waiting list, like Phil said, and that they are becoming longer. And but my question is on the focus on the early intervention, particularly embedded in teams in schools. How far does that go, and is it done in a large scale, small scale? Is there any plan? Can you just explain if there is anything which is currently ongoing, or is it going to be in the future?
It's a bit mixed. I mean, I can start this one off. It's a bit mixed at mental health support teams at the moment. I'm having a bit of a conversation with the regional office and the Integrated Care Board at the moment about those, because it was a manifesto commitment from the government. And we've done a bit of an exercise about how many mental health support teams are in school. These are teams of clinical staff that go into schools to support school staff in relationship to children and young people's mental health and emotional well-being. And the teams vary in size and makeup, but generally the same. There's a bit of a prescriptive approach to it, and we look at all the areas about what they have, and we know in the ICB who's got what particular team. Suffice to say that we are short in the East Riding. Hull, it's about on par, but in the East Riding it is short, as is North Yorkshire. The rest of our landscape is generally reasonable. We're still short of about 26 teams across the Integrated Care Board. We should have about 47. So at the moment we're trying to look at the funding of to how we start. We've got to do it by 2030. So we've got a bit of time to do it, but we're looking at the implementation of that. So what we're saying is that this year we need to have at least another one within the East Riding. I think there's about 2.5 at the moment, and we need to have another 1 or 2 within North Yorkshire. So to answer your question, Priyanka, is yes, there is a real issue to do that and to equalise it out across the Integrated Care Board. The funding is an issue about how we finance that, and then the second thing is how we get the staff to staff that. But we have got some within our organisation, but we are short when we look at the data across the patch in relationship to East Riding. There are some in East Riding, just not the coverage we would expect. And I hope that answers the question.
Yes, thank you very much.
Okay, thank you very much. I can't see any other hands up. I've got one question. I think it's important to raise this because I know we've discussed it at the People and Organisational Development Committee I attended, and also the Quality Committee, and that's on the Supreme Court judgment on the Equality Act. Obviously, the Chief Exec's report includes the work that is going on. I would like to know, when will we have information and reports to provide reassurance to the board that we are operating in line with the Equality Act? Because clearly the judgment has affirmed what that should be with relation to sex and gender reassignment, and clearly there are protections for both groups of people.
We had a long conversation with the exec team yesterday, and just suffice to say that we are probably one of the forerunners of an NHS organisation in doing this work. The majority of NHS organisations that we've contacted aren't doing anything, waiting for guidance from NHSC. We are not. We're looking to see what we need to do, both from a workforce point of view with our staff health and wellbeing, but also from our patients' point of view. So there was a paper that went yesterday to the exec team setting out an approach. We're going to have a task and finish group with clinicians, service users and some of our managers to design how we do that and how we rebadge some of our rooms that we've got in relationship to suites, etc., to accommodate patients, and the same for staff. And we need to get on with that. So we've given a short timeline in relationship to that. We will put that paper through the People's Committee. And that will be, hopefully we'll give an update at the next People's Committee to make sure the People's Committee happen, and that will obviously then come through the board, through that committee to the board at this stage. When we've done more cohesive work, depending on what the People's Committee advises, we'll bring that direct to the board. But we are operating in a bit of a vacuum. So there has been the Supreme Court judgment, but it is a bit of a vacuum for that at the moment. So we are trying to fill those voids as best we can. We know that we will probably not get it 100% right to start off with, but at least we are actioning it, and we are setting out some work that we need to do. Vicky, do you want to add anything?
I don't think I would add anything further, Michelle. I think you've covered everything there. It is on the People and OD Committee agenda, the paper, for June.
Okay, right. Thank you for that update. I think it was just important that we did that because I know it was picked up in the committees that I've mentioned, which was good to see that was already happening. So thanks to everyone for that. Okay, thank you. We'll move on then, in that case, to the next item, publications and highlights report. Can I just say, I think these reports, Michelle, are really great. I think the information that's being provided by executive leaders are really great as well. Sorry, I see 2 hands up. Keith,
No,
and
can we
then-
ratify the policy?
I was just
Yeah,
going to
sorry,
say, I
we'll
think
do that.
we have
Yeah,
to
sorry
ratify
about
the
that, yeah.
papers, don't we?
Yeah, thank you.
Thank you, sorry. Right, so can we ratify the retirement policy, the care programme approach, and they're the two policies? Everyone happy with that? Thank you. And then we've got the consultant appointments for Dr. Salman Afzal, Dr. Vineet Sukumar, and Dr. Shamala Shabazz. Happy to approve those? Yeah, good. I haven't missed anything off, have I? Okay, thank you. Right, we'll move on then. Publications and highlights report, Michelle.
Yeah, thank you. I'm glad that people like the report. So thanks for that feedback, Chair. Again, we've just pulled out the national roundup of guidance, information report, and the relevant directors put where that is and where that is going to be filtered through. And hopefully, then if we track it down, we can see how it does progress. But I'll just open it up to questions as usual.
Any questions to Michelle? No. Oh, sorry, Stuart. Thank you.
Well, less a question for more of a comment. There seems to be a lot of initiative overload going on, and are we keeping up to speed with all the things we're supposed to be doing at the same time? It's a rhetorical question.
No, all I can is really agree with you there, Stuart. At the moment, it is just that one of those areas at the moment where we're just getting a bit bombarded with things, but we're working through it.
Good,
thank you for the observation, by the way. Appreciate it.
Wheat and chaff.
Okay, right then, moving on. If there's no others, we move to number 9, emergency preparedness. Lynn.
You're on mute, Lynn.
Sorry about that.
I'm glad I'm not the only one this morning. Thank you, Lynn.
Makes me feel better too. Yes, thank you, Caroline. This is the annual report for emergency preparedness, resilience and response. 1st of April last year to the 31st of March this year. So I'm assuming people will have read the report, but just to recap a little bit, it does remind the board of the position that we achieved in relation to the compliance with the national EPRR core standards last year. It does specify that there has been during the last year specifically a very strong focus on training, specifically for our tactical and strategic commanders. That we have followed a programme of exercises and testing, as you would expect us to do, over the last year as well. So we've run communication exercises and tested various business continuity plans. Every time we run a test or an exercise, we follow a rigorous debrief process in order to extract the learning and also to put improvement actions in place where they are required. We continue to work in partnership and participate in the relevant forums with our other agencies and with our ICB as well in order to ensure that we are as prepared as possible. At the end of the report, there is a summary of the actions that we will be focusing on over the coming year. Key to that is achieving compliance with the national core standards when the assessment takes place again around sort of September, October time. And obviously the board will be appraised of that outcome as soon as we have the position understood. Otherwise, very happy to pick up any questions.
Thanks very much, Lynn. Steph? Oh, Steph?
Hi, thanks, Lynn. Yeah, can you hear me now?
Yeah.
Thanks, Lynn, and thanks for the report. I'm putting my EPRR champion hat on, which, as you know, I enjoy doing occasionally. And really good report. First of all, I'd like to welcome the appointment of the new senior manager for EPRR for the Trust, which is brilliant, and I look forward to meeting them fairly soon. Just a couple of questions. For Resilience Forum, Local Resilience Forum, for Hull and East Yorkshire, we are direct members of that forum and active members. In North Yorkshire, obviously, where we have our community services and hospitals, we are not. That role is taken on by the ICB on behalf of the health sector. So I'd just be interested to know how that impacts on our effectiveness and our engagement in this agenda. And the second one, it just seems really strange in terms of our assessment criteria that we continue to have CBRN and HAZMAT as measures, which make our figures look worse than they need to be in terms of compliance. And I'm wondering whether there is any possibility or any move to remove those from our compliance requirements, because we're never going to meet them and they're not really relevant to our specific service. Thank you.
Thank you, Steph. Both really good questions. So on your first point about participation in the local resilience forums, we are very clear that we feel the benefit of being directly involved in the forum in Hull and East Riding. And have made that clear to our ICB and indeed our colleagues in North Yorkshire. There are no providers, so we're not the only provider that are not on the Resilience Forum in North Yorkshire, but because we've got that ability to compare and contrast, we make that point persistently that that would be our preference in North Yorkshire, but so far that arrangement hasn't been changed. However, we will continue to persist in demonstrating why we feel that there are benefits to us in that respect. On your other point about CBRN and HAZMAT, Steph, another really good point that given the breadth of services that we provide, we don't perceive ourselves as a lead agency in responding to that type of scenario, and that the expectation in terms of our preparedness overall, we would say, is probably higher than it is warranted to be. All mental health trusts raise that sort of issue, and community trusts as well. As it stands at the moment, there is a national sort of conversation still taking place about that position, but as it stands right now, it isn't changed. So this year's core standards will still require of us what was required last year as well. In saying that, we have obviously in our preparatory work for the coming year undertaken work around CBRN in order to prepare us, but we're doing that systematically as well and asking our ICB to help us with that, because we do need that expertise that lies in other agencies to support. So we are doing that, but I don't disagree with you that in terms of where we sit by way of response, it does feel disproportionate.
Okay, thank you for that question, Steph, and that full response, Lynn. And I can't see any other hands up. So can we look to approve the Emergency Preparedness, Resilience and Response Annual Assurance Report, please? Everyone in favour of that? Yes, thank you very much indeed. Thank you, Lynn, and all the team working in this space. Thank you. Move on to item number 10, and it's Kwame Care Quality Commission Mental Health Act report, which is also up for approval. Kwame.
Thank you, Chair. Just to say that this report is from the CQC. It's a helpful report, and it reinforces the significant and persistent pressure that happens in mental health nationally, especially with inpatient care. There are a few key areas which the CQC has highlighted, which include workforce shortages, discharge planning, restrictive practices, patients' rights, and health inequality have all been highlighted by the CQC. As part of the report, clearly these factors can affect the quality and safety of care for patients. We have, in the report, we've looked at all the proactive approaches which we have discussed in mental health legislation group and various operational forum as well as EMT on how we are meeting these challenges in Humber. I've also referenced some of the details work that we do in each areas in the report. There are other things we do, including the culture of care work, which we've talked about to tackle the persistent inequality and to foster inclusive right-based care. The CQC has also highlighted inappropriate detention, suboptimal environment, which that is being looked at nationally as well as locally. In addition to that, my last point is about the progress of the mental health bill, which is going through Parliament, which we are monitoring through the work in mental health legislation group. It's always very interesting to watch the debate of the parliamentary debate on the mental health bill. And we will continue to make sure that when the bill comes through, in sound governance, effective workforce practices, the focus on co-production will be implemented. And we use the board as well as the mental health legislation as an oversight. So these are the main things with the report, and I would want to take any question from the rest of the board on the report. Thank you very much.
Steph, as Chair of Mental Health Ledger, is there anything you would like to add here?
Thanks, Chair. No, we discussed this in detail at the committee. It's worth a look, actually, of the CQC, the summary report, if anybody's interested. But I think Kwame's covered it comprehensively in the report. Really good issues raised. Really thorough piece of work the CQC's done, actually, and really relevant with the new legislation coming in.
Thank you, and I found the report really helpful with a sort of, from a Humber perspective, having that sort of narrative happening there as well. Phil?
Yeah, the report's really helpful to see what we're doing about it. I think in Mental Health Legislation Committee we talked about blanket restrictions, and it's just really an ask for everybody when they're going on visits just to check that out. We've got an audit register, but just check out when you've been going on in inpatient environments to check if there are any reports of any blanket restrictions, just so that we triangulate that, so that we can be assured that they're not being imposed inappropriately.
Okay, thank you, Phil. Maybe I'll take away and discuss with Michelle for some of our visits, particularly from NEDS, if there's particular questions we should be thinking about that tie into some of the reporting to board. Obviously, when we do these visits, it's not an inspection, it is about getting to know, but just to have in the back of our minds some of those issues might be quite helpful for non-executive directors. Stuart.
I agree with that last point, by the way, Caroline. Mine's thank you for the report, Kwame, very, very clear. And a high level of assurance I sense from the information you've given us. I've got a more general question about how on our risk assessments for the trust more broadly, are we clocking, do we have somewhere a kind of risk of non-compliance? I suspect if we do, it's not. I'm not seeing it because it's not high enough to kind of go over the threshold of the risks that are reported. But it's a more general question. Are we having an eye to compliance with all the standards we need, both in, let's keep it simple, in terms of patient safety and caring?
Yes, we do. And majority of these restrictive intervention in care, it goes through the steering group, mental health steering committee, and goes through the mental health committee, and we talked about it, especially with things like restrictive intervention. We keep an eye on it. We have an audit trail of it. I do present a performance report to the mental health legislation group about each of these indicators to make sure that we keep our eye on it.
Thank you.
Thank you. Okay. I can't see any other hands up. Therefore, thank you very much, Kwame, for the report. Thanks, Steph, for your input on that as well. Is the board happy to approve this report today? Great. Thank you very much. Thanks, Kwame. Okay, then we move on then to freedom to speak up. I think we have Alison with us. Sorry for keeping you waiting, Alison.
Morning, Caroline.
Morning.
Thank you. Thank you. Morning, everybody. So thank you for that. Colleagues on the board will remember that we had a board development session on the National Guardian's Office reflection and planning tool, where there was quite a lot of discussions, and individuals with specific roles and responsibilities were also required to complete that, which then gave us our development plan over the next 6 months. That development plan, which aligns with our strategy, has gone to the Workforce and OD Committee for approval. Since then, we've also had an internal audit of our freedom to speak up policies and processes, which gave us an overall rating of significant assurance. So there was a couple of minor recommendations, and we've just about completed those. So bringing this report really and the associated action plan to the board's attention for approval. And any questions? Thank you, Caroline.
Thanks, Alison, very much. Are there any questions from the board around this? Michelle?
No, just to say that just verbal reassurance that we have just done the internal audit that will go through the various processes that does give significant assurance on the work that we're doing. So that's just to give a bit more of the board reassurance today in relationship to the development plan and actions afoot.
Yeah, and of course we've had Alison come and discuss with us aspects of reviews and what have you at the strategic board sessions as well, which has been good to have as well. So no other questions then. In that case, are we happy to approve the reflection and improvement plan? Yes, we are. Alison, thank you very much.
Thank you,
and
everyone.
to everybody, to all the guardians, to all the ambassadors as well. Thank you to all of them too.
Thank you, Caroline.
Okay, moving on then to item number 12. Michelle.
Yeah, I'm not going to go through this in a lot of detail, Chair, at this stage. I'm sure we'll have further conversations about the actual work that's taking place at NHS England. It just gives you a bit of an outline that there is lots of work currently taking place and lots of I think pressure in the system in relationship to changes that are happening in relationship to NHSC, ICBs, and obviously subsequent provider collaborative discussion. So I've just set out a little bit of the framework here that people will be aware of, thanks to Stella as well, about the move of NHS England into the Department of Health and Social Care, alongside the developing ICB as that strategic commissioner, and a little bit around there. There's a triangle on page 4 about where that fits in with the regional team and providers. From a provider point of view, we've not been given much direction apart from the comprehensive assessment framework, which we already knew, and the sort of the new regulation process. We have got some templates to fill in about corporate benchmarking, which we'll come on to later as well. But they're just a little bit around the developing that thinking about what is a strategic commissioner, which will be the role of the integrated care board, that and the lead for developing neighbourhood teams. There's also the issue around regional office and what their remit is, that beginning to pan out a little bit like more a performance monitor. I suppose the first thing for us is the issue around staff and staffing, and obviously there's quite a lot of pressure in the system that we're working through. So it's just a bit of an outline, Chair, at this stage. I'm sure we'll pick up things later a bit more about it, but I just thought it would be useful just for the board to see some of the guidance that's coming out about the ICB, but a little bit of a health warning. It is subject to change, as we know and do get used to within the system. The long-term plan, the 10-year plan, is due out imminently, but we've been waiting for that for a while.
Is it June the 15th, June the 11th, or June the 15th, something like that?
That's what they keep saying. But it is a movable feast. So that will probably concentrate heavily on electives and waiting lists and the areas that were in the manifesto, which is understandable. But I'll leave it there at this stage.
Thanks, Michelle. Stuart?
It was very useful to see it all in a short report. Good. I was sort of struck on the pyramid diagram on one of the pages that there's still 3 layers before you get anywhere near the front line. Are the regional teams going to be part of the single national body, or are they going to sit somewhere between?
I don't think the answer is, I don't think we're 100% sure. They are going to be part of, we think, obviously if NHSC and the department come together, they'll be part of that, but they'll be like their offices out in the regional. There will be a lot smaller. The idea of both the regional offices and the ICBs that will be smaller. And I think Jim Mackey's intention, obviously the new chief executive of NHS England, is to reduce the overall operating model within the NHS because it is clunky. But I do think it will be subject to a little bit of change as we go forward, especially the diagram on page 7.
Thanks a lot. It'd be good to see those triangles, in proportion to their relative resource size, wouldn't it, eventually, where we're hoping to get.
We maybe can have a conversation about that later.
Public reassurance. Brilliant. Thank you.
Yeah, I think the image sort of suggests it all goes through, and in fact, some areas it will be a direct relationship between providers and regional teams on some issues, and similarly on some national issues as well. So the triangle doesn't quite work for what is happening in a way. You're right to point that out. Dean.
Yeah, thank you, Michelle. Really helpful update, and I think most people would acknowledge that a lot of duplication has, sort of seeped into the system, and it's good to sort of look to reduce that. I think part of the difficulty is that when you announce a reduction before announcing the shape of the structure, you inevitably get gaps emerging, and it's probably one of those issues that's important for each of the committees to keep an eye on. So we've just had the EPR report, for example, EPPR report, Lynn, the role of the ICB, etc. Workforce functions are likely to disappear and something else may emerge in there. So just as those risks emerge, as things become evident, it's just important that we sort of capture those as we go along, as you've highlighted there on the paper as well. But really helpful report.
Yeah, good point. Thanks, Dean.
Yeah, it is. And can I just provide some assurance as well that I have asked at various sort of national network meetings about, whilst this is all happening, and as Michelle said, subject to change, the work that we are doing on mental health provider collaboratives in our area, about that continuing at pace. And sort of the messages I've got back is, yes, carry on the work you're doing. Don't be, put off by other things that are happening. So that was quite a positive thing, I think, for the work that's been happening there by everyone involved in that partnership. Okay, I can't see any other hands up. So thank you for that, Michelle. And I suggest we take a 5-minute break here now and come back for the staff survey results item for us to get into. Thanks, everybody. See you in about 5 minutes. Thank you. Okay, welcome back everybody to Humber Board today, and we are on item number 13, and we have our colleagues from IQVIA attending to present. Vicky, would you like to make the introductions, please?
Thank you, Caroline. Yes, we have Lucy here from IQVIA today to present the 2024 results. I'm sure Lucy will pick it up, but it's just to make you aware that these results are from organisations who are commissioned IQVIA to administer their survey. There are some slight variations to the national results, which were published in March, but I believe the board have already seen these, but it's just to make you aware when looking at the presentation.
Thanks very much. Lucy, welcome.
Hello. Hi. Thank you so much for having me this morning. I will just start sharing my screen, just make sure you can all see that. Just 1 second. Okay, is that showing on your screens?
Yes, thank you.
Okay, perfect. Okay, so hello, I'm Lucy Bosher. I'm one of the senior consultants within the Insight and Feedback team at IQVIA. So we are not part of the NHS, nor are we part of the CQC. We're a private company, and we administered the survey, the staff survey, on your behalf alongside a number of other organisations within your sector. What I normally would ask is if you can leave questions to the end of the presentation, that would be appreciated, unless there's a burning question that you have that's kind of stopping your understanding of any of the slides. But if you could if somebody could just make me aware of that, because I won't necessarily see you. I'll be sending, I have already actually sent a copy of this presentation through to you, but if there's anyone who hasn't had that or you need a further copy, etc., just let me know. Okay, so as we'll know, the staff survey is a key measure when looking at staff experience and supporting your staff. There's a number of factors that contribute to staff retention, and it's important for you to understand how to focus on those areas, how to improve staff retention, and obviously not lose those vital skills and experience, or actually incur any unnecessary recruitment costs. Also, the health and well-being of staff is key to developing a happy workforce, so it's so important to get the views of staff on a consistent basis, and that's why the staff survey comes into play. Okay, so you will know that the survey is run between September and November 2024. Your comparator group is the acute and the acute community trusts, of which we actually survey 65 trusts. So it's one of our biggest comparator groups that we survey. The national results, as we were just mentioned, the national results were released on 30th March. Now figures will vary very slightly to the national results, but in our experience is not by a great deal. Okay, so looking at the response rates to start with, so we can see here that for substantive staff, your response rate is 56.2, and for bank staff it's 31.4. For substantive, we generally say that to get over 40% is good. Anything over 50 is really good. Over 60 is rare. No one generally gets over 70 in trusts. So obviously you can see where your score is just showing in the really good kind of bracket, and is kind of pushing towards this over 60, which is rare. So that's encouraging. You can see your bank score, however, let's have a look. So 31.4. It has gone down slightly since the 2023 results, but it's still comparatively a lot higher than what's judged as good for bank staff, which is just kind of a 19% area. So there's slight room for improvement there year on year. Okay, so looking at the summary of your scores, just to explain, the orange box down the centre column, that's your 2024 score. The green colours to the right are where you have shown significant change or significantly better than the sector. And to the left-hand side is your comparison scores since the 2023 survey was done. So we can see for your People Promise scores, all but one are significantly better than the sector score, and all have shown slight improvement since 2023. The only People Promise score to not significantly be higher than the sector was for People Promise 7, We Are a Team. However, just looking at more closely, it's still higher than the comparator organisations, but it's only very slightly. So that's your score is 7.20 compared to 7.18 for the comparator average sector score. Just to explain here as well that when we talk about significant difference, we use a calculation called the Z test. I don't know if you will have heard of it. And this means the significance will vary from question to question, and that's dependent on its weightings. So it could be a change as small as a few percent, other times much larger, but that will indicate whether a score is significantly changed from either the sector or from the previous year. We can sometimes find that your overall theme score may be showing significantly better or worse than the sector, or it is significantly improved or declined. However, the questions that sit under it do not match that same significant movement, and that's a result of some of the questions within that theme showing some change, even though it may not be significant. When it's all combined, they will all add up and to make the significant overall theme score. We may see some examples of that as we go through. So I just wanted to try and highlight that now. Okay, so overall the scores for Humber Teaching NHS Trust, that they're very positive, they're excellent scores and should be a cause for celebration amongst your staff, and certainly share the positive results with the staff, with your staff groups. We recognise that obviously it's a very challenging time for the NHS, especially now with there's a lot of impactful and significant change. So the scores that show that your trust is showing, it's showing a trust that's responding well to those challenges. Okay, so looking at question benchmarking of your scores, just over a third, so that's 41 questions, are significantly better than your comparator group. And then we've got 3 questions that were significantly worse and 64 questions that showed no significant change or the data was not comparable. The 3 questions that were worse were actually team members understanding each other's roles, feeling a strong personal attachment to their team, and staff working on unpaid additional hours above their contract. Moving on to look at the staff engagement and morale scores. Okay, so your staff engagement score overall is significantly better than the sector, but for the sub-themes of motivation and involvement and at question level also, there's no significant differences. If we look at the scores in more detail, we can actually see that your trust scores are all better than the sector average, but they have also nearly all shown a slight decline since 2023's scores. Okay, so looking at the sub-theme for advocacy, we see here that it's a far more positive picture for under advocacy, with all scores are significantly better than the sector, although all scores are better than the sector, but not significantly so. But all scores are better than 2023. Sorry, excuse me. Let me just go back. All scores are better than the comparator group. Excuse me. And all scores are also better than 2023's, but not significantly so. So the positive scores within that sub-theme of advocacy will be what's driven up the overall staff engagement score, which we just saw on that previous slide. So moving on to morale, the theme score for both the sub-theme scores thinking about leaving and work pressure are significantly better than the sector, along with many of the question level scores that make them up. 2 exceptions are for staff saying that they are able to meet the conflicting demands of their job and there being enough staff in the organisation for them to be able to do their job properly. Those scores are showing slight differences from the 2023 and from the sector. Then with just continuing on the theme of morale, within the sub-theme of stress, there's a reverse picture with almost all question level scores showing no significant difference, with the exception of staff saying that they have a choice on how to do their job, and that is significantly better than the comparator group score. But if we look from 2023, we can see that has actually dropped since 2023 very slightly. Okay, so we're going to move on and have a look at the people promise themes individually in a bit more detail to see what's happening in the different areas. Having already gone through your results, I can see that the scores are generally in line with 2023 scores and close to the sector. So rather than going through every single individual question in turn, I will pull out sort of scores of interest and whether there's any correlation between different areas. So to start, people promise 1, we are compassionate and inclusive. The main theme score is above that of the sector, as is the sub-theme score for compassionate culture, and all but one of the question scores. Your friends and family test questions, which the CQC pay particular interest in, are significantly better than the sector. So that's staff thinking about leaving the organisation or recommending the organisation as a place to work, or receive treatment or care for their friends and family. The only question where staff are not reporting as positively is around them feeling that their role makes a difference to patients. So that score is just below the sector and has dropped since 2023, but there could be a number of reasons for that, and further interrogation of the data should be undertaken just to have a look to see what exactly is happening in those areas. A good place to start might be your staff comments if you haven't already looked at them, and you can be able to kind of interrogate that data on our Solaris reporting platform to see what to highlight what the possible issues could be. Also look at which area within the organisation that scoring is coming from. It may be that it's you can pinpoint that it's happening in a particular area, or that it's happening in multiple areas, but you should just see what your staff are saying around those issues just to try to help support any change in that area. Continuing the theme, you can see that for compassionate leadership, most scores for immediate managers have improved since 2023 and have also scored higher than the sector. There's no significant scoring here though, but there is some room for improvement to push those scores towards a significant difference for 2025 survey. We are compassionate and inclusive continued, and we're looking here at the diversity and equality scores. It's far more favourable in this area and all above sector, but there have been some declines also since 2023. This is particularly noticeable in the scores around staff experiencing discrimination from patients and the public, but it's also true of experiencing from colleagues. I believe this is part of your action plan to focus on why your staff are feeling like that, so that you've already had some discussion on where to take actions in those areas. And here we can see that score I mentioned earlier about staff saying that they feel that they have a strong attachment to their team. So this score is actually significantly worse than the sector score and has also seen a slight decline since 2023. Just moving on to those additional questions about discrimination. Looking at your trust figures, we can see where they're based on the grounds of ethnic background. This is significantly better than the sector. However, overall, for just grounds for discrimination, the scores have generally declined for other types of discrimination. That it's true of many trusts that we've surveyed, reported to, in terms of discrimination based on ethnic background, on religion. While we've had no actual notification from the coordination centre regarding that, we could hazard a guess that there may have been those scores may have been impacted by the race riots in 2024. So particularly your trust having a significantly better score for ethnic background is very encouraging. it's not the same across many of the trusts we've spoken to. Moving on to we are recognised and rewarded, People Promise 2. Scores under the theme are mainly in line with the sector, but the sub-theme 2 of the question scores are significantly higher. Staff are reporting they are happy with their level of pay, which is an encouraging score, as we mainly see little difference to the sector or the score. It's generally significantly below, even though pay is set to particular levels, we still have some negative reporting in that area. The other question that scores more favourably against the sector is staff feeling their work is valued. So that means that's quite an interesting score if we think back to staff feeling like their role makes a difference to patients. So that was significantly worse to the sector. So even when staff are feeling valued by the organisation, they are not necessarily feeling the same about patients and service users. And you want to have a look at why, what the reasons around that are. Okay, so People Promise 3, we each have a voice that counts. Bit of a mixed picture here under this theme. The theme score is significantly better than the sector, as is for the question around a choice in how to do your work, but the remaining questions under autonomy and control don't score as high and also have seen a decline since last year. But under raising concerns, the situation again is reversed, with all of the question scores being above the sector, and they have all improved since 2023. It's really encouraging to see here that the staff feel that they are able to raise concerns about issues they see around unsafe clinical practice. They also feel confident when they do raise concern that it's going to be addressed, and the organisation are actually going to take some action, which encourages staff to feel safe to speak up about raised concerns. We do find a lot of time in other organisations that this can be a problematic area, and staff who have had the confidence to actually raise concern and stick their head up, that the organisation may have scapegoated them, or they may have been treated differently as a result, and so other staff will not feel encouraged to follow in their path and raise concerns. So here we can see the continuation of that positive scoring, and these against 2023 results, they are generally in line with the scores for the previous survey. Okay, so moving on to People Promise 4, we are safe and healthy. The score for a sub-theme of health and safety climate is very positive, having significantly improved since 2023 and significantly better than the sector. Staff also score more positively for having the right equipment and to do their work, and feeling the organisation takes a positive action on health and well-being. One question to perhaps keep an eye on is the reporting of physical violence at work, as that has dropped from 92.7 in 2023 to 89% in 2024. So while that's not actually classed as a significant decrease, you may want to review the reasons for that decline. And then conversely, staff are more likely to report incidents of harassment, bullying and abuse, with a score that has improved from 58.7 in 2023 to 65.7 in 2024. So looking at the sub-theme of negative experiences, most of your scores have remained fairly stagnant since 2023 and are broadly in line with the sector scores. 3 standout scores, however, here. Firstly, staff experiencing musculoskeletal problems, but also both of your scores around staff experience discrimination from patients in the public and from other colleagues are better than the sector average. Okay, so if we move on, we can see that the score, which is significantly worse than the sector here, and you haven't got many, but this is for staff saying that they work additional hours above their contracted hours, and that work is unpaid. So that's obviously something to keep under review, as we know this can lead to work-related stress, burnout, low morale, and perhaps in the worst cases, it can lead to staff leaving the organisation. However, your scores for burnout are actually significantly better than the sector, but for work-related stress, although it's slightly above the sector, it has also dropped since 2023. But for paid overtime, the score is improving over time. People promise 5. We are always learning. Your staff reports positively on the development opportunities that are provided within your trust, and feeling the organisation is offering them challenging work, and that they have opportunities to improve their knowledge and skills, and they feel supported to develop their potential. They're all scores that are significantly above the sector. That's obviously a very positive for a trust of your type, and is overall one of your strongest areas. We can see here scores for staff appraisals, also very positive and significantly above the sector. And also for the coverage of appraisals, that's very encouraging, because generally a score over 90% is evidence of a well-performing organisation. And also you can see clinical supervision opportunities. They are also a positive score where the trust is performing better than average. Okay, moving on to We Work Flexibly. The majority of scores, again, above average in this area. Nearly all have shown an improvement since 2023's results. The one question where the score has dropped and is staff saying that they're able to achieve good work-life balance. However, the score is, it's better than the sector. We do generally find that post-pandemic, we're finding that many organisations are struggling to get their staff back into the workplace, into that kind of workplace environment, and having worked at home or in a hybrid situation, there is a bit of resistance to get people back into that workplace when they could be working from home. So the scores here are very encouraging. Okay, so final people promise theme 7. We are a team. There's just one score in this area that hasn't shown any significant difference, and that's for teams saying they understand each other's roles. That's actually 2 points below the sector and has dropped 2 points since 2023. So that's another question that you might want to keep under review. So is staff receiving respect from colleagues, as although not showing significant difference, it has also dropped since the previous survey. And also, we would also recommend that you have a look at the numbers in more detail. Even though it says it's significantly better or worse, in some instances, as I said previously, the differences are very small. That's because the range of responses is so tight. Okay, so then we are moving on to just finally looking at the recommendations. So here we're just recommending, they're generally based on your lowest performing score questions. So on that basis, we would recommend that you look at the staff reporting that they are working paid additional hours, and look why that's happening, review the rotas and staffing levels to ensure that staff don't become burnt out. Utilise bank staff wherever possible, though I realise there is a restriction on budgets for using bank staff. Also address the cases of discrimination within your trust as particularly experienced on the grounds of age, sex and disability. Put actions in place if you haven't already to positively address concerns, encourage further reporting of incidents, and ensure that basically a zero tolerance policy is adopted and reminds patients and service user of what acceptable behaviour looks like. As I said, so those recommendations were based on your lowest scoring questions, but one other area that you may want to put some focus on is around teamwork, and particularly staff feeling that they have a connection to their colleagues and that they understand each other's roles. So, I mean, they are likely to have a direct correlation to the way that the team is working together, and in order to kind of raise profile of people's jobs and understanding of people's jobs, it's good to take as many opportunities as possible and perhaps utilise team meetings to clarify what jobs roles are, etc. Okay, so that actually brings us to the end of the presentation for your staff survey results. I know that you're already some way down the road into your action planning and implementation. This is a slide we actually just include with all our presentations, just to take you through the different steps you might want to think about when you are reviewing your data through to implementation. So yeah, you can have a look at that if you so choose. I am just going to stop sharing now. I can see you all again. Hi. Any questions that you had? I will try to answer them as many as possible, but if I can't, I'll go away and get answers for you. Over to you. Oh, sorry, you're on mute.
Thank you, Lucy. Appreciate that presentation. Stuart.
Yeah. Oh, excuse me, Lucy. It's Stuart here. One of the non-execs. One great presentation, by the way.
Thank you.
Very clear and easy to follow. And I'm always interested in digging below the surface. Does your data set allow us to identify those groups of people who are either not agreeing or disagreeing? And I'm struck, for example, where even we've got a good score, for example, 80% of people saying we believe the trust priorities are about patient care and users experience. Can we understand what the other 20% are saying, or what they think the priorities might be?
Yeah, I mean, that's why we would always recommend looking, and I don't know if you've had any additional work done by us on sort of the thematic analysis and comments or anything, but we would also always recommend looking at what your staff is saying. So whether that could be a starting point, looking at your staff's comments on our Solaris platform, but otherwise doing staff representative groups and holding focus groups or holding discussion meetings. So you can, because obviously the staff survey is a lot of the quantitative data, but the qualitative is so important to get that rich data on what people's opinions and views are. So I would use that as a starting point to say, what are the different issues, and then perhaps take them to the staff groups and then have those as discussion points.
Thank you.
Thanks very much, Stuart. Dean.
Yeah, not so much a question, just a really helpful presentation. I know this has been a sort of year-on-year improvement that we've been looking at in terms of overall sort of culture change. But I think, as we've said some of the things in the chat there as well, really positive, I think, to see about how people perceive their line managers and sort of and the support that they give, because I think that's really important for sustaining this, isn't it? Because it's if people model the behaviours that they see, then people coming up the ranks will see that sort of behaviour and continue to model that behaviour, where, as in the past, perhaps there's been different behaviours that have been exhibited. So I thought that was really positive. And a bit like Stuart, really, I think there's some really useful prompts here for when we do visits in terms of triangulating, is having a look about, what could make things better to, help more effective team working or interdepartmental team working. And a bit like you, Stuart, on the question about, patients not our first priority. I think something like 80% of them say it is, and I'd sort of assume that it must be something else that they saw. But often when I ask people about it, they were referring to patient processes at times of pressure, when one group of people are making a decision that they believe is in patients' interest, for example, to flip a ward from male to female, but the people transacting that see the patients and don't necessarily think it's the right thing to be doing. So it's not that it's something different, it's just sometimes the way that processes are seen and perceived, but very strong scores and some really helpful ways for us to prompt questions when we get out and about some visits as well. And well done to the team all round. I mean, it's sort of led by HR, this, isn't it? But clearly a lot of interaction in terms of the application of action plans in the past through Lynn's team operationally, and Sarah's team in terms of nursing, and Kwame's team about sort of medical staff as well. Sort of see that sort of culture change that's going on and feeling embedded, I think, is really positive.
Absolutely, Jenny, you're absolutely right in terms of the immediate managers and also the senior leaders. When we see organisations who are engaged and communicated with, it's obviously it's generally the lead of the senior leaders and then down to the immediate managers that actually kind of affect that positive change. If they're engaged, then they can also engage their staff. But if it's a disengaged leadership, line management, etc., then they find themselves feeling disencouraged.
Okay, thank you very much. Any more questions or comments to Lucy? I can't see any hands up. There's a few chat in the chat box around looking at how we could sort of try and sort of see correlation between a positive and then negatives to see, sometimes you can get an imbalance, can't you? Someone might feel very positive about something, but actually there might be some other negative impacts of some of that if it's not handled well. And I suppose partly, if people are working in a hybrid way or virtually online, they might enjoy that as a positive choice, but are we doing enough to make sure that they feel included and see their part in the wider picture, getting to know the rest of their team? And obviously lots of organisations who are hybrid working, it's a feature, it's with us, but how do we make the best of that, I think is something is always going to be a challenge, which we can look at. And maybe some of these contradictions almost play into that sort of situation, that you can feel both positive about something but also maybe not feel you're getting the support you need at the same time. And I know that your committee, Dean, will be obviously looks at that all the time as well. Michelle.
Yeah, thanks, Lucy, for the presentation. You got a lot in there in the time, so thank you for that. We will obviously, I'm sure, circulate the slides. Just a couple of things. I just really want to send out my thanks to the team, really, the exec team and the leaders on this call, because when you think where we were bottom by a huge margin. And I know it's been almost a bit of a consolidationary year. I have been spoken to by the team in relationship to it. I do think there's some positive steps, and the ones where it looks significantly worse, it's only a little percentage, 0.5 or 0.1.5 or whatever. That doesn't mean we don't need to work on it. But also thanks to Dean and the People's Committee as well, because I know that they really, really scrutinise the results and look at the action plans, which obviously will continue to go through that committee. And there is the nuance that we do need to work on, Stuart. You're absolutely right. This issue about you neither disagree or agree, because it always goes as a negative. And there's nothing more frustrating, I can assure you, than getting one that patient care is not our central theme, because as my colleagues know, it is one of the things that I am absolutely, and it's about explaining that the out of areas, the patient metrics that we do when we come onto the performance report. It might be useful for us actually to say when we're presenting the performance report, well, actually these metrics are engaged in relationship to how we're dealing with patients, and it doesn't just become a report. It's about bringing that into some sort of life in relationship to we collect these data so that we can see how we are dealing with patients and looking after patients. So I think it's about that language, and maybe something the board could have a bit of a conversation on at some point, Caroline, around how we do that in relationship to how we all, including me, present something that we're presenting this because it affects patient care, because we do get staff listening into these meetings. But I just wanted to really just take the opportunity just to thank the team, really, because I'm obviously all their team, because it's another good report. There's lots of work to do. We know that. We're never complacent. I mean, there are some areas that are frustrating, but we are it was going in the right direction. So we just need to continue that work. So thank you to everybody that's been involved and continues to be involved.
Thanks, Michelle, very much for that. Lucy, thank you as well. Where do we get the slides, Laura? I put some in the chat books. Where can we access them?
I'll circulate them to the group shortly, Caroline. Thank you.
They're not in the portal then?
No.
Okay, can we just sort of, if we can circulate them to the board, that'd be great. And if there's copies in the portal or whatever that we can access as and when, that would be really helpful as well. We'll take away, Michelle, your suggestion to have a sort of another chance at a strategic session to think about this patient first, staff support balance, what we're doing. I think we have done a lot of work on that. I think we've seen since other areas that's improved around the patient first, but sometimes it still creeps in. Sometimes in some of our reports, we start with the staff and then we come back down to the patient. And in some ways, the patients are first. What we do to support our staff helps our patients. Sometimes they're sort of making sure that we're on top of all that is still needs to be attended to. But let's do that and take that away. And also the point made about some of the findings can we'll think about outside of this, some sort of almost like a note or brief for colleagues doing visits, especially NEDs, on some things to think about when they go to visit one of our services, to keep that uppermost in their mind would be helpful. Great. Lucy, thank you so much for your time today and for working with us once again.
Thank you.
On this latest iteration of the staff survey. Thank you very much.
Thank you. Great to see you all today. Thank you. Bye-bye.
Okay, moving on then to the board effectiveness reviews. Let me just get that in front of me. It's for approval. It's all, I think, pretty explanatory in the report. Any questions for me on this? Is the board happy to approve? Thank you very much. Move on then to item to Stella, committee effectiveness reviews.
Yes,
part of the same basket.
Yeah, very similar. The committees also undertake their own annual effectiveness reviews, and this report highlights the outcomes from them. So all committees are operating effectively and have the relevant sort of processes in place. There are some proposed changes to the terms of reference for the majority of committees, and those are detailed in the paper and there for approval.
They're all pretty minor, aren't they, the changes, in many respects, same for the board as well. Any questions? Stuart?
Yeah, just a quick one, Stella. You know the diagram, it's on page 220 of the pack, of all the groups reporting into the quality committee. On my version, they've all been kind of crossed out. Is that because they've been abolished, or are you just not showing them on this page? Because that's actually quite useful to see the feed up into the quality committee.
So a decision was taken, wasn't it, Stuart, that the reporting groups, the operational reporting groups, would report into EMT in future, with any exceptions escalated up to the committee. So the terms of reference have been updated to reflect that decision.
Right. So if I wanted to see the whole picture of, I've got my audit chair hat on here as regard to the flow of sources of assurance. If I wanted to see the whole picture, the quality committee would be then, there'd be another layer, which would be the EMT, would it? And then these other groups as well?
Yes, so we have actually just produced a diagram on that. It's literally just being worked up at the minute.
Okay, so I think basically, I don't know for everybody else, but Stuart, you just froze there for me.
Sorry.
I think what you're suggesting, and I don't know if you missed that, but Stella was just saying, is that we made decisions about the reporting groups, where they should go. It's a bit like when we had those discussion about minutes and what have you, where they should go as well. Yeah. But I think, so we all approved that, but I think what you're saying, it would still be quite helpful to see some sort of chart that showed the flow of where these reporting groups was reporting to, in this case, EMT, and what have you, just to see it holistically. And I think Stella was saying that is being worked up.
Well, we've got that.
My primary question was, have those groups been abolished and either simplified or whatever? But that, yes, I would find that quite helpful to get the total picture of assurance routes for my audit chair role. Yeah.
I think it would be all good for all of us to see that. Michelle, you said we've got it, so over to you.
I've got my hand up that yes, we've got that, Stuart. And I think there's two things. You're absolutely right. One, we need to make sure that you're still getting the assurance to the committees. So we'll review it, and obviously that comes with the insight reports and how the chair and the exec take those reports back from an assurance point of view. But we have done a committee before and after structure, so we'll certainly get that to audit committee. What I've suggested, it goes to all of the committees. It's just about to be circulated to the exec team, and once they've had a look at it and made sure it's what we've talked about, what we've agreed, and everything else, then we'll send it out to everybody so that the committees can have a look at it, make sure they're happy, and then we'll review it every year just to say, well, are there any voids? Is there anything that we need to be aware of? That's the idea.
Brilliant. Thank you.
Okay, thank you. Thank you very much. Anybody else? No, thank you, Michelle. Right, okay, everybody happy to approve the committee effectiveness reviews with that proviso that we will provide for Stuart and others. I'm trying to just find the right word. Something that shows us where everything is reporting into and what's happening, basically. A diagram, always like that. Great. Everyone approves that. Okay, moving on to fit and proper person compliance. We've gone all through the procedures again this year. In fact, the return has been submitted today, I think, or yesterday it did. Is everybody happy with this report? Great, thank you very much. Moving then on to Insightful Board. Sarah and Stella, I think.
Thank you, Caroline. The report in front of you provides an update in relationship to the Insightful Provider Board guidance that was published at the latter end of last year. The report details how we've socialised that with senior managers and then the work that's taken place through our committees and how the strategy element will be taken forward through our board strategic board development session. So really the report is here just for noting, so there's an appreciation of the work that's been taken to ensure that we've done that assessment against the guidance. Thank you.
Thanks very much, Sarah. Any questions to Sarah on that? Good. Okay, thank you. We note that report and we move on to finance report. Pete.
Thanks, Caroline. So this is the finance report as at the end of April. It's a bit of a light touch report this month, as it always is in April, given there's no formal NHSE reporting requirements and we're dealing with kind of the ledger and the year-end accounts. So pleased to report to the board that we did record a position at month one that was consistent with our NHSE profile plan. You can see within the report we've shown the profile for the plan for the year, which takes us to about an 800,000 deficit by the end of July, and then recovery back to our break-even plan position. And that's primarily the timing of our efficiency programme and some of the BRS stretch target we put into the plan. You know, our cash position remains strong. Just for assurance, we have provided for a pay award of 2.8% in the month one position. So I'll stop there, Caroline. I'm happy to take any questions.
Thanks very much, Pete. Any questions from colleagues? No, I can't see. Can I just ask that obviously the pay awards, I think in the report it talks about that it was basically based on our refinement at 2.8% across all NHS staff. And of course, the announcements are higher than that. Yep. I just wondered, any thought, because I know obviously from previous years, Pete, you know, as a mental health trust, we don't necessarily always get our pay award fully funded in the way the acutes do. So I just wondered if you wanted to sort of say anything about that.
So obviously the announced pay awards last week were greater than the 2.8%. That was in the planning guidance, Caroline, as you just pointed out. We are still awaiting formal confirmation from NHSE of the approach to fund the pay award, but we've been given informal assurance that the pay award will be funded. The danger for us as a trust is if it's funded through the tariff system, because as you quite rightly said, I think there was an article in the HSJ again, that for community providers and mental health providers, the bulk of our cost is staff. So we have an 80-20 pay non-pay ratio, but the tariff system is more aligned to the acute sector where it's 60-40. So there remains a risk. But at a national level, they are saying the pay award will be funded. So whether or not there'll be a return or not, or whether or not that's a risk, I guess we're waiting to see, Caroline. We've calculated what the pay award is, but until we get confirmation of the funding system for it, you know, we'll bring that update through the correct governance route.
Yeah, thank you very much. And that was flagged, that disparity, a recent Northeast Yorkshire event with the new chief exec there. Stuart.
Yeah, really quick one, Pete. That graph of the monthly deficit profile is very, very useful. Just check the title of that particular graph. But that kind of reporting and that visual reporting, I think, really helps concentrate the mind on where we should be. So thank you for that.
Thank you.
Okay. I can't see any other questions there. We'll move on. Thank you, Pete. And thank you also to all your staff, not only for the past year, but I was going to say the past 24 hours, the way things are shaping up in the NHS. Every day is quite a tough day at the moment. I know that. So thanks to all your staff. Okay, let's move on to the performance report.
Lovely. Thanks, Caroline. So again, this is the performance report at the end of April. The report is in the new format we agreed at the strategic board last month, where we looked at our performance report and how it reflects the quality and clinical priorities for the trust, you know, with patient care being at the centre, as Michelle alluded to earlier. Within the report, there are 3 new indicators. So we've got liaison 1 hour response, which we had a good conversation on earlier about the A&E streaming, urgent care 2 hour response, and virtual ward occupancy and admissions. We did retire the friends and family test and the generic RTT charts from the report. And again, we discussed that at the board last month. For this month's report, we have highlighted that we continue to see some good areas of performance across our workforce metrics and clinical supervision. And it's pleasing to note the virtual ward occupancy remains, up at the higher end. We highlighted on the front sheet, we have got some operational challenges on the recording of contracts with the change to EPR, but we are working through that and we have an action plan for the EPR optimisation group. And can I suggest before we go to questions, I bring Lynn in just to update on out of area and waiting time. We discussed a little bit earlier and then open up for questions, Caroline.
Thank you, Pete. Lynn?
Yeah, just on out of area placements, obviously we continue as recorded in the Chief Exec's report, all of that work around patient flow. So we continue to implement the MAID methodology. We've got that in place across all of our inpatient areas now, and we are continuing to see positive impact of that overall. We have seen a reduction in our out of area placements, PICU and adult mental health. We do have a plan, as we discussed before, to address the PICU out of area position by adjusting our inpatient provision. Plans are in place to take that forward. We've got estates work happening to support that as well. So I am optimistic that we are going to continue to see improvement of that patient flow position to have a reduced, sustained position and reduction on out of area placements. On waiting times, as we've talked about already today, neurodiversity remains our challenge. We are seeing reduction in our adult neurodiversity services because that's why we are just targeting the resource that we've got, matching that to demand, and where we can't do that, working with our ICB colleagues, we are redirecting service users to the right to choose approach. So that has meant that we are reducing our waiting times overall. We're obviously not seeing that same impact on children's ASD and ADHD. We have been working through the Mental Health and LD Collaborative and the wider ICB to look at proposals that would see the right to choose funding redirected to providers to reduce our current waiting times. So there is appetite for that in our ICB, which is good. So we are expecting, I can't give you unfortunately a date on when we will see that start to have impact, but the case is strong in order to do that. That does mean that we would need to continue to look at the alternative models as well, and we are still waiting for national task force guidance as well around that. That just obviously, as we've discussed many times here, that a diagnostic only focused model isn't the model that is going to be sustainable going forward. But with that right to choose potential change, that could see us, as we've succeeded before when we've had short-term funding, to reduce the waiting times. So that's what we're working on at the moment. The general over 52-week position, excluding ASD and ADHD, as you can see from the chart, has improved. We've got targeted recovery plans in every single area where we've got an over 52-week wait. I'm expecting those plans to be expedited over the next quarter as well to really see those other over 52s, which are generally quite low, but improved further. So the continuing focus remains on reducing all of our waiting times. Going back to the point that was made earlier around staff survey, I do think it's really important then we're talking to our staff that these aren't just targets and performance indicators. They really are about patient care, patient safety, and achieving access to our services in a timely way. And I do think we need to continue to work at making sure that we've got that connection between those messages. It isn't just about performance, it really is about improving patient care. I'm happy to pick up any questions in that area.
Thank you, Lynn. Stuart.
Yeah, thanks, Lynn. It's very helpful context and clarification on a number of things in the report. Just to make the link between what we heard earlier with our guest speakers, on the perinatal service on page 270 of the pack, that's the rolling 12-month number of women accessing perinatal, which seems to be on the downward slope. So even accounting with the fact we've actually got some lower numbers from 12 months ago dropping out. Have we got any insight into what's happening there?
We are looking at that very closely at the moment, Stuart. We do think there is some EPR change issues impacting recording there as well. But the target obviously is about women accessing. Nothing has changed in our model to prevent women accessing when the demand is there. So we are looking at that. And I think it goes back to our board story today as well, that making sure that, you know, people who, you know, genuinely have good awareness of the provision and the service as well, and that communication, social media campaigns that we've been running anyway, continue to be a focus.
Yeah, and making the link to what we were talking about this morning, if actually the numbers reducing because earlier on in the women's experiences, they're getting early preventative intervention,
getting better,
then that could be a success story in itself.
Exactly.
Absolutely.
Yeah, thanks.
Yeah, no, thank you for that, Stuart. Steph, and then I've got Phil.
Thank you. First of all, Lynn, thanks for the explanation on the 52-week waiting time. That's really good to see, and good to see some focused work going on there. And also just compliments to the team on the good work on the virtual ward occupancy. That's really encouraging, and it's definitely going the right way. So that's really clear to see. And I think all these charts actually now are really easy to read and really make sense in terms of patient care. There's just one chart that I just welcome a little bit of explanation, and that's the community mental health team access chart, which is on page 269 of the pack. I just can't quite work out what's going on there and whether we should be concerned about it.
I think, yeah, give Lynn a bit of chance to find that.
So I have found the charts. Actually, that wasn't here. I say Pete might be better able to comment. I think we've got ESR sort of reporting issues here predominantly as well. But Pete, you might be more up to speed than I am on the recording.
I think this is linked to the recording and the work we're doing with the teams on the recording of contacts in System 1, Steph. So it's a 12-month rolling chart. So we've probably got, I'm going to use the word 3 months of bedding down since we transferred the system within the mental health division. So we highly suspect, and the work we're doing with the team is on the recording of contacts in System 1.
Okay, thanks, Pete. That's understood. Do we have a time scale for sort of fixing this? Is it?
I would hope you start to see a recovery trajectory in the next report, Steph, because some of that work, you know, we've identified some of the solutions now. So it's probably a time, I hate to use the word a timing difference, but it's probably a timing difference between the report at the end of April and the work we've done over the last 2 months starting to bear fruition.
Okay, thanks, Pete.
I mean, I know that is, I mean, there's a reference to that on the front sheet, isn't there, in terms of work underway. Maybe just in future, if that's something like that, you could just say slides without getting too long on the front sheets. But this is affected slides, blah, 1, 2, 3, whatever it might be. Just then sort of, forewarn colleagues that that's what that is, what that strange sort of shape of the chart is really all about. Great. Phil.
Yeah, just on that, just to confirm that Lynn reported into Quality Committee the EPR issues in recording, and I think we might have to be a wee bit patient because it felt quite a complicated issue to sort out. So a little bit of patience. But just a couple of issues I'd just like a little bit of assurance on. That the memory assessment waiting times have deteriorated, and that's been put down to sickness. But I just wondered, are we thinking beyond how we stabilise that and reverse that? And also just to ask if we'd noted the sudden deterioration in liaison psychiatry, the 1 hour response rate in A&E. So just those 2 questions.
Can I pick up the liaison one first? Can people hear me okay?
Yeah, you're fine.
Yeah, the liaison one is absolutely definitely due to the EPR change, Phil. So we know that performance hasn't changed, but obviously the way you report activity, Phil, you'll probably be very aware in System 1 is very different from Lorenzo. So we're doing some proper diagnosis, as Pete mentioned earlier, to rectify that as quickly as we can. But I can assure you performance hasn't reduced.
Yeah, okay, that's reassuring.
On memory assessments service, Phil, so we have had some short-term absence. We are challenged already with that 18-week standard because of the increase in demand outstripping the capacity that we've got. We undertake perpetual capacity demand analysis. We've changed our processes significantly over the last 12 months, but still demand's exceeding the capacity. Obviously, it's a constant conversation that we're having with commissioners. We constantly look at the model of care as well to try and address that. So it's a continuing focus.
Thank you. And obviously that seems like one that we need to continue to modify what our intervention is, and also empowering the communities differently, because it's just going to increase, isn't it? I mean,
absolutely.
Population, yeah.
Okay. I can't see any other hands up, so thank you, colleagues, for those questions and a few takeaways there for Pete and Lynn for the report, next sort of round of reports, really, particularly on that EPR issue, maybe. Just to remind non-executive directors, we have got tomorrow morning between 9 and 10 our online governors briefing. So I'll try and make sure that we get it recorded. But if you want to come along, it is focusing on, Lynn's going to be there, our emergency department streaming, not necessarily the best word. It's not on Netflix or any other streaming channel, just to make sure they're all covered. But it might be helpful, again, those bite-sized sort of chances to look at those issues are quite helpful. So please join us. You are very welcome to join all those briefings, non-executive director colleagues. Okay, thank you very much, Pete. Thank you very much, Lynn. We can now move on to report on the use of the trust seal. Michelle.
Yes, thank you. Very quick report, usual reporting of the trust seal. We've used it 3 times, as noted on page 3. Just ask the board to note the use of the trust seal in accordance with our governance processes. Thank you.
Thank you, Michelle. Okay, is that any questions? No, that is noted. Thank you very much. Moving then on to Stella, changes. Review of standing orders, scheme of delegation, standing financial instructions, and these are for ratifying Pete and Stella.
Do you want me to do this one, Pete?
Yeah, go on then.
Yeah. Okay. So the standing orders, standing financial instructions, scheme of delegation have all been reviewed.
Stella, sorry. I don't know whether you and Lynn are on the same sort of frequency, but you're a bit crackly there.
Can you hear me okay, Caroline?
We can hear Pete okay, but you're crackling up a little bit. Pete.
I'll present it, Stella. You can jump in if I miss anything. So obviously the scheme of delegation, standing orders and financial instructions are reviewed on an annual basis. We did do an interim review last year in relation to the Procurement Act, and we've reviewed the documents again for the annual review, and there are a couple of changes in there. One in relation to the Procurement Act, further changes to the Procurement Act, and one in relation to use of the trust seal. So the changes did go through the audit committee earlier this month, who were supportive of the changes in the documents. So it's brought here today to board for ratification, Chair.
Thank you very much. Any questions from anybody maybe who wasn't at that audit committee meeting? No, is the board happy to ratify those changes? Yes, great, thank you very much. Now we move on to, again, Pete, you're up. Compliance with the provider licence annual review.
Yep, so again, our annual review of the provider licence, Chair. This has been through executive management team, and we have updated it, as we always do, with a comprehensive review of evidence to support that as a trust and as a provider. We believe we are fully compliant with our provider licence. So again, I'll take it as read and happy to go straight to any questions.
Okay, any questions from anybody on that? Nope, thank you very much. That's for noting and discussion. Good. So we are, and that will go to governors in July, won't it?
Yes.
Pete, yeah, okay, thank you. So we are at item number 23, the board assurance framework update, and we have Oliver with us, I hope.
I can't see him yet.
Oh,
Chair.
Sorry, Chair. He should be joining any time now.
There he is. There he is. There he is.
Welcome,
Hi, Oliver.
Oliver. Just in time, Oliver. Perfect timing.
Good morning, everybody.
It was all planned.
Indeed.
Okay. Oliver, over to you. Unless you want to say anything, Michelle.
No, just obviously thanks, Oliver, and everybody I think around the table, because we've done quite a lot of work on this. So always work in progress, but I'll pass over to Oliver just to take you through the main areas and the positive assurance and some of the work that we need to do. And as always, wait for questions. Thanks.
Thank you. Thank you very much.
Thank you, Michelle. Thank you, everybody. So,
Oliver, you're a bit quiet. Sorry to interrupt you. You are a bit quiet there.
I'll have to just enunciate a little bit more just because I'm in a funny room. Apologies. So in terms of the board assurance framework, as ever, this represents an end of quarter position. So this is for the quarter four. Obviously, in terms of the sort of planned next steps for the board assurance framework, we'll be moving away from the quarterly reporting sort of model to be focused very much on contemporaneous reporting. So obviously in line with the board work plan, it will now be coming sort of 6 times a year in line with each of the board meetings, sessions. So it will be next be coming after today in July, which will be the first iteration in the new template that I know you've all seen via the strategic board session. So it gives us a good obviously mechanism to be able to be really contemporaneous in the information that we're capturing, specific around the inputs around each of the strategic goals, the outputs that we're seeing for that kind of up-to-date position, and then any actions that we need to address specifically to those gaps where we may not have outputs that we're looking to achieve. So it'll be a bit of a radical shift in the way that we'll be doing it going forward, but I think it's hoped that it'll really allow us to have constructive discussion around the board assurance framework through both the board assuring committees as well as the board. I think the main elements just to highlight in terms of this iteration, obviously it's been fairly static in terms of the overarching scores from a quarter 3 into quarter 4 position. I think it's pretty much held the line when it comes to each of the assurance ratings. Obviously, when we're looking at the BAF on a much more frequent basis, when we're looking at it 6 times a year, and obviously it will go through the board assuring committees and EMT alongside that as well, it will allow us to be really focused on that current information. So I think we're probably likely to see more, I suppose, movement in terms of the scoring, more up-to-date recognition on the board assurance framework document, and it will allow us to really have those sort of meaningful discussions looking at specific areas. So I'll take the document as read. As I said, obviously it's not going to be representing the most up-to-date information, so I fully appreciate you will have had board reports that have come through today which probably has more detailed current information. Just to bear in mind, this does represent that end of quarter 4 position as ever. Obviously, we are moving away from that, so we will have that more up-to-date review each time going forward. But this is essentially kind of the closing off of that chapter with the previous format of the BAF, moving us towards that new version going forward, which is quite exciting. Will allow us to obviously develop our work around that. Next steps in looking at the risk register reporting and how we can link that in and really have that meaningful relationship between the two documents as separate items, but obviously being interlinked. So I think we are due to obviously review the trust risk appetite, which I think is planned for an upcoming board session, and then obviously then that will be reflected in the new risk management strategy, which will be coming over the next couple of months as well. So lots of going on in terms of risk registers and board assurance framework work within the organisation. Happy to take any feedback as ever, and obviously any comments that we need to consider from yourselves as we go into that new reporting mechanism going forward.
Thanks, Oliver. And I know when we met this, we had, I think at the strategic board meeting, we had a discussion to take away. Maybe it was Pete was there. Is there still the opportunity for non-executive directors to feed any viewpoints to yourselves on this, as it's obviously we're getting into the next version of it, but is there any, have you got a timeline on that if anyone's got any further comments they need to throw in just to take away?
So we are in development of the document at the moment. It will be going to EMT in June for a kind of first look at it for that next version. It will then go to EMT again in early July and then board in July. So absolutely would welcome any feedback from non-executive directors, any comments, just to obviously allow us to really strengthen that document. So absolutely, there is that time to allow us to do that, and obviously would value any feedback. That'd be really useful.
Okay. Well, I'll just take that away to work out with Laura, just a reminder email to all the NEDs, and if they need some extra documentations to have another look at, documents to look at to feeding any further views. Thanks. Any questions from board? No. Okay. I think we have discussed this a lot in other forums, haven't we? Fora.
And just to prevent any what looks like inadvertent radio silence from us all. Well, obviously, each of our subcommittees looks at the relevant pages, and the audit committee last week before had a look at the whole thing, and we identified, didn't we, members of the committee, that there are certain things that, because of the point in time reporting that are going on now, that aren't reflected in the narratives. So it's inevitable we have this kind of moving feast all the time, and I look forward to the next iteration in the new look version, Oliver, particularly. So thanks for your help on that.
Thank you.
Thank you. Yeah, and I think there's a couple of the committees that I've observed since we last met that have done exactly that, Stuart. I think quality was definitely looked at some of the areas in the BAF for them when I was at that meeting. Okay. Thank you. Okay. Thanks, Oliver. July is coming when hopefully we will have our platinum BAF to move forward with. Thank you.
Absolutely. Thank you.
Okay. Moving on then to the Assurance Committee reports. Start with Keith, please. Finance Committee.
Thank you, Chair. So this reflects a Finance Committee meeting on the 15th of April. So it feels a little bit way back in the past now from where we are now. I'll take the report as read. I think just a few areas I'll highlight. So I think formal kind of thanks and achievements around the year-end position, Caroline, of 23-24, which finished with a very small surplus, but it effectively break even, which I think the committee wanted to reflect to the whole organisation, Pete's team, but the wider team, of the effort that to achieve that in the financial climate that we currently live in within the NHS. So I think it's important to register that from the board's perspective. I think in terms of risks, probably impossible to pass by still the underlying deficits in the ICS system and the strain and potential risk that presents to us as an organisation as part of that ICS, and those risks haven't gone away, even though some of them may not be reflected directly on paper, but they still exist. I think two areas under commissioned work which are important, one around starting to look at scenario planning for the next 3 years. So rather than looking at the kind of in-year piece, trying to take a longer term view of our overall position in terms of budget, but in terms of cash flow and in terms of the strain that puts on the organisation. So Pete and his team are starting to look at how we reflect that through the Finance Committee and then onto board as part of the strategic view. And then also a very detailed conversation around given the increased focus nationally on productivity and efficiency and how we spend our NHS pound, if that makes sense. How are we going to review that in Finance Committee so that we can bring that to the board? And we're doing some work around what does that look like in terms of how we monitor that and how we assure ourselves that we're doing as much as we can around that efficiency and productivity, view that in the Finance Committee, and then we're able to bring that through these reviews up to board to make sure we're giving ourselves the right level of assurance on the work that's being done in that area. So I think they're probably the keys. I'll take everything else as read, but happy if there's any specific questions from anyone.
Thank you, Keith. Any questions from anybody on points that Keith raised? No, thank you very much. Steph, over to you for Mental Health Ledger Committee.
Thank you, Chair. Yeah, it was a very full meeting last time. A lot of agenda items, a lot of topics. I just want to highlight a couple of things. Mental Capacity Act. I'm wanting to give a little bit more profile to Mental Capacity Act issues within the committee, which we did this time with a really interesting piece of audit work, which highlighted some needs for changes to our systems and some training requirements, which was really useful. We received the Associate Hospital Manager's annual report, some positive news there on recruitment of 4 new hospital managers. Myself and two other non-exec directors are keeping an eye on this area, and we'll be looking to observe some panels fairly soon. And of interest, we had a look at some of the health inequalities issues around race and deprivation, which were really interesting, actually. Particularly around detentions under Mental Health Act and the use of restrictive interventions. While the numbers are relatively small, there are some significant issues here for us. And we took a look at what the Trust is doing around, quite a lot of work the Trust is doing around these areas to embed anti-racist and anti-discriminatory practice. For example, PCREF, the Patient and Carer Race Equality Framework introduction, and the culture of care within the Trust, looking to address some of these issues. So that was really interesting, in fact. But otherwise, if there are any questions or issues others wish to raise on the committee.
Thanks, Steph. That last issue was actually a part of, came up in presentation at the Culture of Care event the other week, actually. And I certainly raised it as some of the issues at the EDI event we had the other week as well, around the different impacts, particularly for Black men in mental health settings compared to others. Thank you for raising that. Any questions to Steph? No? Okay, thank you very much, Steph. Moving on then to the Audit Committee Assurance Reports, Stuart.
Yeah, this is last week, and once again, on the whole, a positive tone and set of findings for the meeting to consider. Just going to bring out a couple of things, sort of by exception, that we want to follow up. One is that we had a good discussion with the Community and Primary Care Division on their risks, on their risk and their system and the method of risk management. And we were slightly concerned about a particular risk relating to the fire alarm at Whitby Hospital, which we asked for more clarity on in terms of a way of resolving and a date for resolution. And then secondly, we have some more work to do to follow up on some audits at Millview Lodge and Maester Lodge in relation to handling of service users' money and property. So the record keeping needs a little bit more follow up, and that's very similar to some findings we had at a previous audit of the same theme in different locations. I know the management team are on it, but I'm raising those simply because they are the exceptions that confirm the rule that generally the audit environment is strong.
Yeah, thank you for that, and thanks for you raised with me the issue around the fire alarm. Where are we on that, Pete, in terms of the fire alarm reporting and who takes, who holds the ball on it, I suppose, with it when these things happen?
Well, I think so. That was precisely the question, wasn't we? Had sort of various people involved, but nobody felt as though they're really saying, I'm going to resolve this. That's what we asked to be clarified.
So I will do a note around the board, Caroline, for clarity, but just for assurance to the board, the fire alarm at Whitby is working and has always been working as intended. It's a cause and effect fire alarm system, so there's probably a bit of training we need to do on site, and we have been on site and provided some training, but there's probably a wee bit more just to confirm understanding, because when the fire alarm does go off, it doesn't go off in the full building, it'll only go off where the fire is detected, and then the fire detection panel will beep. And just for a bit of assurance, our fire officer, Paul Dent, has observed 2 fire evacuation exercises at the hospital, and the North Yorkshire Fire and Rescue Service are happy with the design and the operation of the system we have up there. But I will do a formal note around the board just for reassurance.
Thanks, Pete, for that. Thank you.
And that's good to hear, because we didn't have that level of explanation at the time. So it's precisely because you just closed the loop we needed closing. So thank you.
I'll get that sent today.
Great.
Yeah, that's great. Thank you very much for that, because you only had the meeting last week, didn't you, Stuart?
Oh, we did, last.
Yeah, exactly. Okay, thanks for Pete for doing that. Okay, anything else, Stuart? Any other questions?
Not from me.
No.
Thank you.
Thank you very much indeed. Let me just make sure I've got this in order here. Apologies for this. Hang on, I've moved my notes around. Gosh, where's that gone? Okay, look, I'm just going to take the one I've got in front of me. Phil, quality report, please. Quality committee.
I thought you were missing us out. I'll take it as read. I've just noticed that there's a typo on the front sheet, and it says February 25. It relates to the 8th of May meeting. It was a good meeting. The quality accounts were approved for presentation to the board, and I believe that they're coming to the next strategic development meeting for approval. And Sarah's promised that next year the quality accounts will be shorter, more patient, and service user friendly. So you've got a big piece of work to be done, which is going to happen. And just to confirm what Caroline was saying, that we talked about the Supreme Court judgment as well. But I'll take any questions.
Okay. Any questions to Phil? No? Okay. Thank you very much, Phil. People and Organisational Development Committee, Dean.
Thank you again. Report there for everyone. We received the updates from the 3 subcommittees that report in. That'll be the last time we do that, as we discussed earlier. So some nice read across to the board discussion there. We'll just get assurance and escalations there in the future. We also, as Stuart said earlier, had a discussion around our elements of the BAF and looked at the risk register, and with some positive assurance there that the positive impact has been on vacancy rates and lower turnover for some time. We've been able to reduce the scores in terms of those vacancies. Having said that, this is one of those assurance and also additional work to do. So consultant vacancies still remain higher than we'd like them to be, despite some excellent work. So those are always in a area of focus too. And then we did all the sort of administrative stuff of the work that we've covered earlier around looking at our effectiveness review. And as a result of that, are looking in that sort of continuous improvement way about sort of just rejigging the agenda to focus on areas that we think we need to put some more time and effort in, as the system is changing and there's emphasis on different things. So we'll make sure we reflect that within the committee as well. But again, happy to take any questions.
Thank you very much, Dean. Obviously, there's always a few people and organisation development issues come up in board meeting that I know you and Vicky will take away. No questions? Okay, thanks very much. Okay, thank you, Ned Chairs, for all of that. Thank you. Move on to strategic development meeting agenda. Michelle, I think there's an addition, isn't there, on here now under the business items? I think you wanted to put in. Can you just remind me what that addition is, or Stella?
I think, can I throw that out to Stella, because I'm not sure I can fully remember myself. It's changed that much. I know we want to have a guest speaker. We want to have a guest speaker to set off the strategic board in relationship to the strategic landscape, but that's already on the agenda. So, Stella, can you remember? I'm sure you can.
Yeah, it's the social values report.
That's it.
That will come to this meeting now.
That's it. Thank you.
I thought it was, but I didn't want to give the board wrong information, so that's absolutely fine. Thank you.
That's it. Yeah, so that's the answer. Just on the business items, I mean, I think on some of these, I know the annual report, a number of us have had a look at that and offered amendments in and what have you. Presumably, you know, we could get those out to people quite early on, because some of it is probably near completion, so that people have a good chance to have a look at them before the meeting. I think that would be quite helpful. Can we take that away?
Yeah. Sorry, before Stuart comes in, can you also make sure people have got that in the social values report as well, Stella?
Yeah.
We're trying to put that on the same timeline as well. So, and you may not be as familiar with that. Don't worry, it's not a very long document, unlike the annual report. So.
Yeah, I think it would just, as I say, I think it would just be helpful rather than waiting for the deadline for papers. We could get that out in advance and give everyone a bit more time to have a look in, you know, and rather than just a week before. I think that would be really helpful. And also, we are trying to keep these business items to a minimum on these strategic board agendas as well, as much as we can. Stuart.
Yeah, and just in terms of process and flow of work, the audit committee meets on 19th of June from memory, which that's the annual kind of reporting audit committee. So a few of us will already had a really good going over of the hopefully the final draft of the annual report, which has already been in circulation, plus the account. Yeah. So we may not need to spend much time on unless something completely unexpected comes up, which is not going to happen.
Right. Okay. Thank you very much, everybody. If there's no other comments, we can move on. I haven't received any items to escalate. Any other urgent business? No. Okay. Review of the meeting. Any comments on the questions in the box on the agenda? Comments? Okay. Fine. That's the end of part 1, our public board meeting for May. It is now 12:22. I suggest we come back at 1 o'clock for part 2. Is that okay with everybody? Great. Thank you everyone for your participation this morning, including our external speakers. Well, some of them are internal, but from within the organisation. But thanks to all of those as well. See you at 1 o'clock. Thank you.